Assalamu alaikum, good morning. Staying active, body and mind, it's like adding quality to your years, not just years to your life. And the best part, it doesn't matter when you start, just start. Good morning, everyone, and welcome back to day 2 of High Fort International Lifestyle Medicine Conference. I'm Hanan Al Hindi, and I delighted to hosting today's program together with my co-host, Abdul Majid Al Moka and Abdullah Al Ghassab. Yesterday, we covered the core pillars of lifestyle medicine: how nutrition, movement, sleep, stress control, social connection, and avoiding harmful substances can make a measurable difference in preventing chronic disease. Our speakers gave us practical strategies, strong evidence, and clearly picture how lifestyle change truly drive better health. Today, we are building on that foundation with a new set of sessions that diving into deeper, bringing fresh perspective to the field. Let's get started. And I would like to introduce our first session moderator, Dr. Mohammed Zayed, ambulatory care, clinical pharmacist, and director of King Salman Specialty Hospital at High Health Cluster. Welcome, Dr. Mohammed.
السلام عليكم. السلام عليكم. Give me mic, please. السلام عليكم. Thank you, Hanan, for this introduction. And good morning, everybody. Good morning.
Morning.
Wake up. Just I would say I'm honored to participate in this amazing conference. And also I would say thank you for the scientific committee to invite me for participate in the fourth edition of Lifestyle International Conference. Now we'll be starting with the amazing session with the distinguished speakers. This is under the title of the integration of the model of care toward the Saudi Vision 2030. Before starting, just I will announce about the QR code about the dialogue. If you see it in the side of the screen, and also there is a QR code for the session for evaluation and for your question. Our first speaker, Dr. Mishari Al-Jam'ani, will be present the lecture under the title Saudi Model of Care. Dr. Al-Jam'ani is Executive Director of Saudi Model of Care and Consultant Family Medicine working in High Health Cluster. Welcome with me, Dr. Al-Jam'ani.
Thank you, Dr. Muhammad. Thank you, and good morning, everyone. And I'm happy to be here with you this morning and warming by you. Especially, we have a cold day today, actually, in Hail. And I have a special thanks for the scientific committee for inviting me to introducing this special lecture. If we see our, for this year, we talk about Live 80. And we will see in Saudi model of care, our aim also is to live or have a life expectancy to 80 years. We focusing on the value health, which equal the healthcare services outcome over the cost. in National Vision 2030, we reach to the life expectancy 80 years by studying the more cause of death in Saudi Arabia. We have 4 main cause of death: cardiovascular disease, diabetic and kidney disease, and also the respiratory disease and the maternal and neonatal deaths. And each one we have to decrease it by percentage: 40, 40, 40, 70 equal 80. And you heard the Minister of Health yesterday. Here in Hail, we reached the first city in Saudi Arabia to reach 83.5 years in Hail, and this is from good work in all sectors in Hail to reach this age. When we see the Saudi model of care, we should to know what's the old model of care. In the old model of care, we had multi-facility, multi-system, multi-care to deliver to our patient and beneficiaries. But our beneficiaries was confused how we can reach the services. In the Saudi model of care, we put 6 systems of care and 6 layers to reach each level of this care, and have integrated together to each from our people here in Saudi Arabia. And from the national vision also, we should to transfer the services from in the blue color, it's the old model, to shift it to the green color, the new model. We will shift it from the hospital to the home, and from activity to outcome, and from the treatment to prevention, and from institution to integrated systems, and from physical building to the virtual services, and from fragmented to integrated, and from passive participants to active participants. Here we will see what's the 6 systems of care and what's the 6 layers of services. The 6 systems of care we have first by the keep well system, and I have also the last phase system, chronic care system, urgent care system, safe birth system, and planned care system. And each one of these systems have a multiple clinical pathways and intervention. And the 6 layers of services, in the old model, we have primary, secondary, and tertiary. In the new model, we have a good people with mental, physical, social, and we have active person and good health community. We're starting also before going to the building by virtual care and starting by primary, secondary, and tertiary. Here also we have 6 foundation for health system transformation by purchasing program and sector governance, and also private and third sector participant, workforce, and electronic health and corporatization. If we see here, each system from our system have aim. When we start about keep well, it's mean supporting our people stay well and get well again. And if we see in the planned care, the patient receive a great and consistent outcome for their planned procedure. And in the safe birth, the woman should have support if they have safe delivery and healthy infant. In the sorry, on the urgent care, we should to have support people to get the urgent problem solving in the right time and right place. In the chronic care, we should to have supporting our people to provide integrated care and ease the patient through between the sitting. And in the last phase, the patient during the last phase have their lives by providing the comprehensive care and empowering them to spend the last days within they are most comfortable. So we will actually applying our system of care. We have 42 intervention. This 42 intervention multiply by 2 ways. 15 of them from the national applying like system data and the outcome and the health research program. This is the national level. And that 27 of this intervention, we actually separated to each system to be applied. Starting from the keep well. The keep well, we have a multiple programs starting from health coach and actually community-based wellness, workplace wellness, school wellness, health food promotion, and health edutainment, and last, promoting the Saudi CDC. If we see also in the green color, the chronic care, we should to have the chronic disease screening and case coordinator and community of care. And each one of this intervention in 2025 applied for all in Hail. Last thing, our goal from the new model of care or Saudi model of care, as we mentioned, to have a good community, good communication from each sectors, governance sectors and private sectors, and also the health sector especially. And we should to focus from the treatment to prevention and from facility to the system and fragmented, integrated and passive to active citizen. And my colleague and my team, inshallah, they will complete the impact of each system of care, what we did about the last 40, 40, 40, 70. Thank you, everyone.
Thank you, Dr. Mushari, for this beautiful presentation. And we'll be moved to the next speaker, Dr. Ibrahim Abdul Qadir. Dr. Abdul Qadir graduated from Hail University, from the College of Medicine, and completed a residency program and fellowship program in Riyadh at King Fahd Medical City. Dr. Abdul Qadir is a consultant of nephrology and head of the nephrology services in Hail Health Cluster. Will be present for nephrology disease in the model of care. Please welcome with me to Dr. Abdul Qadir.
Assalamu alaikum. First of all, I will thank everyone for invitation and for attend this presentation. We will talk about nephrology model of care in Hail cluster. Actually, we go through a trip today from my presentation. We have multi-visit I mean, we go through some video. After that, we explain how we can start and what we have and what we have in the future. First, we will show one video from King Salman Hospital. This is our service in King Salman Hospital through nephrology care for our patient. We have multi-services like dialysis center, small dialysis center, peritoneal dialysis. And we have some clinics, specialized clinic. Next video through King Khalid Hospital. The same, we have multi-services there. Dialysis center for 210 patients. And BD, peritoneal dialysis patient there.
بالإضافة إلى استقبال حالات الطوارئ وحالات التنويم. أما الغسيل البريتوني فتتولى عيادة الغسيل البريتوني توفير المحاليل اللازمة للمرضى ومراجعة تحاليلهم الشهرية إضافة إلى متابعة الحالات الطارئة. كما توجد عيادة ما قبل الغسيل التي استقبلت حتى الآن أكثر من 480 مريضاً بمختلف مراحل قصور الكلى، حيث تقدم لهم خدمات الاستشارات الطبية من قبل أطباء الكلى وأخصائي التغذية والتمريض، إضافة إلى الدعم الاجتماعي والنفسي.
Yeah. Next, we have some challenges, especially in Hail, because we have multi-comorbidity, multi-age, like like diabetes, hypertensive, and all the disease related of chronic kidney disease. So we have developed the services in Hail. What I mean before 2020, we have some services, but now we are almost full capacity, full services in Hail cluster. I will show you what we have in Hail cluster. In King Khalid, we have dialysis center, BD, peritoneal dialysis, CKD patient, low clearance clinic. Low clearance clinic, it is from model of care project. King Salman, we have dialysis center, peritoneal dialysis. We have GN clinic with a specialized consultant for GN clinic. And we have onconephrology. This is the first clinic in Saudi Arabia covered by consultant of onconephrology. And we have low clearance clinic also. And we have a peripheral center. We have 8 peripheral center. We cover almost 145 patients for dialysis. We start from عش80 to الحياة. I mean, عش80 50 kilometers, الحياة more 200. And maternity with child hospital. We open recently dialysis center for pediatric patient. We don't have before. Now we have dialysis and BD for the pediatric. We have 5 pillars of base of model of care. Multidisciplinary team. Actually, I am happy work with everyone. What we see here in the presentation, not job for one man show. I mean, we have multidisciplinary team, model of care, hospital director, administration, executive work, and physician nurse. All work together. And we have model of care lead. I mean, we did some implementation and screening from everyone before start our plan. We have also pharmacist care, I mean from the pharmacy. We have pathway with pharmacy in cluster of Hail. We have self-management program, so educate outside the society. There is one study in 2014 from Dr. Ahmed, especially for Hail. We have almost 9% from the population as CKD patient. All the stage, we mean from stage 1 or 2 to 5. So it is big number. Why we have 9%? Because there is more comorbidity and more disease related, like diabetes, hypertensive, other comorbidity. This is the timeline for nephrology care in Hail. Here we start with primary care screening with model of care. We do screening for everyone, every patient visit BHC. We did like a feedback from a patient, and we did all the screening from labs, vital signs, and history from disease from the patient or the family. After that, next step, we open the pediatric diabetes services. After that, from the screening, we know where is the where we can focus of. We start low clearance clinic. Low clearance clinic start with stage 3 and 4, all the patient referral from BHC. We discuss the patient, what is the plan for next 2-3 years, for dialysis or a transplant. After that, after the low clearance clinic, we create a pathway with vascular, pathway with GS, general surgery. We create a pathway with oncology. We create a pathway with a pharmacist, because we believe the multidisciplinary team, it's the best way for work and get the benefit for the patient. After that, we connect all the center, the periphery center, with our specialized center. All the people and patient in periphery, we can see in our center. The next step, we open the specialized clinic. Specialized clinic, especially in King Salman Hospital. We open the GN clinic, onconephrology clinic, and renal biopsy for the patient, because this is the base of diagnostic disease for the kidney patient. And we go for transplant patient and transplant care. Now we have a new project. From our screening, we saw some people need a special clinic. Inshallah, we will open next month with this clinic. It is like a high-risk pregnancy clinic, integrate with nephrology, rheumatology, and OB/GYN physician. This is the integrate coordinator. We have a model for successful system, kidney care choice model, and patient coordination. After the screening and model of care, we create a pathway. We have a pathway for transfer the patient from BHC to a specialized clinic. This model we create here with model of care of Hail, and we announce this one for the company Sahha Al-Qabida, and we do presentation for our pathway. This is in details, and this is the sample pathway. Stage 1 and 2, we can manage through family physician and BHC with general practice. If the patient up to stage 3, we can send the patient in specialized clinic or the hospital. We can manage and control the hypertensive with the diabetes, albumin creatinine ratio. After that, if the control, we can back the patient to BHC and continue the trip of care there in BHC. This is the pathway. Decrease of the patient in the hospital, increase the patient care in the BHC, and everyone from the BHC know what we can do and how we can deal with patient of nephrology patient or kidney patient. This is the strategy, treatment strategy is the same. We focus for lifestyle. We focus for control diabetes, hypertensive, with medication also. But the medication until the last step, if there is some abnormal labs for the patient or abnormal history. So we can treatment as a 4 pillar from this is from the guideline, KDIGO guideline 2024. We start what we see in the screening. We see most the people from primary health care, it is related from diabetes. That means nephrology, diabetes. So we focus from BHC with diabetes and nephrology care. We start as a 4 pillar. We start for SGL2 raise. After that, we can go up with GLP-1. After that, the last medication, it is approved recently from 2024 KDIGO as a ferrinoin. So all the 4 steps we can go from BHC. We can treat the patient from BHC with 4 pillar. And why we choose the pathway from diabetes hypertensive, as I mentioned, because all the patient or 90% from the patient from BHC related of diabetes. And what we have, after the screening, we open low clearance clinic. From low clearance clinic, we avoid emergency patient. We avoid the crash the patient for hemodialysis, and we sit 3, 4, 5 times with the patient for choose the modality of dialysis. So we did a study for the patient, and we have low clearance clinic, almost 480 patients from BHC referral, and we save about 1 million per month. That means if we can start from BHC to low clearance, we save more money from our cluster. What we have as a challenge, every trip or every work, there is some challenge. Our challenge, the staff, coordinator, the patient social, the patient education. So we try do the best for our patient and our staff. Just I will mention our staff from the physician to coordinator, all trained for nephrology care and know what we can do or deal with the patient of nephrology care. We have some data, just I will mention. 2023, we have 50,000 session of dialysis. 24, we have 52,000. 2024. 2025, we have almost 59,000. end of the year, we have 83. Renal biopsy 2023, 0. Now we have 37 patients. GN 23, 24, 0, 25, we have 53 patients. Oncology 30, and BD we increase the number. And we have decreased the transfer of the patient outside of Hail because we have full services here in Hail for every disease and every diagnostic therapy. Thank you.
Thank you, Dr. Ibrahim, for this beautiful presentation. And I saw your effort for the role of the multidisciplinary team participate with you in your unit. And now will be moved for the third speaker. Will be present the presentation about Keep Your Lungs Healthy by Dr. Amjad Tallah. Dr. Tallah graduated from the College of Medicine in Hail University, and also he continued the residency program in Riyadh, and also the fellowship in the King Faisal Specialist Hospital at Riyadh. Dr. Tallah is a consultant intern and pulmonary medicine and head of the service of the pulmonary service in Hail. Dr. Tallah is a head of the pulmonary services at King Salman Specialist Hospital. Welcome with me for Dr. Tallah.
Assalamu alaikum. Thank you, Dr. Mohammed, for such warm and wonderful introduction. So I'll be speaking about the impact of lung disease on the system in Hail, and all the steps had been taken by the Health Hail Cluster. Not merely the treatment strategy, but more importantly, the preventive strategy. So those are my outline: prevalent lung disease, definition, risk factors, current practice, preventive strategy, future goals. So we know for the fact, when we speak about lung disease, the most prevalent lung disease in the kingdom and worldwide is small airway disease, which is mainly bronchial asthma and chronic obstructive pulmonary disease, with the prevalence of chronic obstructive pulmonary disease between 2.4 to 4%, asthma ranging between 10 to 14%. So this is just to emphasize on the importance of the impact of lung disease on the healthcare system. This is a relatively recent study conducted between 1990 and 2019, which shows almost 50% increase in the prevalence of chronic obstructive pulmonary disease at the kingdom level. So COPD is the fourth leading cause of death worldwide, causing 3.5 million deaths in 2021, approximately 5% of all the death worldwide. COPD exacerbation results in 14% increase in the mortality for hospitalized patients and 30% in ICU. It's also the sixth cause of mortality in the Middle East and North Asia region. Tobacco smoking is responsible for almost 70% of the COPD. And if we see on the right side, this is the most prevalent lung disease, bronchial asthma, COPD, followed by pneumonia and other lung disease. But the main purpose of this talk is to highlight the preventive strategy on COPD and the bronchial asthma, because for two reasons. First, they are the most common disease worldwide, and of course in the kingdom. Secondly, the effectiveness of preventive strategy has the highest impact on those two diseases, not like the other disease. So just to go over the definitions, we know COPD is a chronic, persistent, progressive, heterogeneous airway disease that usually progress over age unless we eliminate the risk factor. Usually, most of the time is due to smoking and aging. Bronchial asthma, on the other hand, it has similar presentation in terms of symptoms, limitation of activity, shortness of breath, cough, but it's somehow less likely attributed to smoking, and usually it happens in earlier age. So I'll go through the pathway referral that had been established by our colleague in the primary health care, and we appreciate that, 2023. So if you go through the asthma pathway, we can, I'm not going through the details of the pathway, but we need to highlight a few points on this pathway. If you look to the upper left, the top, we start at the community level where we target the community, arranging awareness day, health campaign, and increase awareness of the impact of asthma COPD. Then if we move further step to primary health care, it's important at this point to have an early diagnosis as possible as we can with earlier treatment to address all the risk factor, etc. And we know that earlier treatment, better outcome. Also, it's important when a patient, for a reason or another, especially in asthma, much more in moderate to severe, when those patients refer to secondary or tertiary health care, we want to make sure there is integrated care, so the patient, when reached and control status, to be referred back to the primary health care to continue follow-up, which is usually more close, more feasible to the patient in primary health care. All the data on this algorithm are obtained from the Saudi Initiative of Asthma and the Global Initiative of Asthma worldwide. More or less the same is applied to the chronic obstructive pulmonary disease. So earlier diagnosis, especially in COPD more than asthma, because we will come later to this slide, we will see what's the percentage of COPD remains undiagnosed, even if they still have some symptoms. So as you see here, we start at the community level, we health campaign, awareness day, then move to primary health care based on the disease severity. Then if the patients need further or advanced care, refer to secondary, tertiary, then back after that to the primary care. So I thought it would be a nice idea to speak from tertiary care point of view, since I'm working in King Salman Specialty Hospital in حائل region. Those are data registry for asthmatic patient in 2024. If you notice on the right side, we have a total male 1,573, with female 2,382. If you see the prevalence of the or percentage of asthma in those patients, more in female 35% and the male 22%. If I move to 2025, despite increasing in the number of the patient in male 1,900 plus and female 2,850, we still have some reduction in the percentage of asthma, those who needed tertiary care. That doesn't mean all asthmatic patients, but with a reduction rate of 11.2, this all happened after this establishment of the asthma pathway. When I move also to chronic obstructive pulmonary disease, we see out of the whole patient coming to the pulmonary clinic, 9.3 male and 0.8 female. When I move to 2025, the reduction rate is 4.7. So again, despite the increased number of the patient who visit the clinic, we have some reduction in the percentage of the COPD patient. This also applied to the total number of bronchial asthma who had an exacerbation that required an admission to the under pulmonary surface. In 2024, the total of 129, then 115 with a reduction rate of 10.8. Also in chronic obstructive pulmonary disease, total 83, then followed by 76 in 2025 with a reduction rate of 8.4. So that, of course, after the implementation of the pathway we have mentioned earlier, and when we shift the care not only for treatment at the level of secondary or tertiary care, but rather optimizing the preventive strategy and health care awareness. So I just want to address the risk factor of COPD. I'm sure most of us are aware of it. Smoking is the leading cause of the COPD. Exposure, whether indoor or outdoor, also is a considerable risk factor. Over age of 40 people are more prone to COPD. At some rare cases, we have hereditary factor. So what's the impact of smoking in COPD? 40% of COPD patients are active smoker. About 70% of all COPD cases occur in people with a history of smoking. Smoking cessation among all the treatment intervention has the greatest impact on lung health and quality of life. So out of 10 patients of COPD, you will find 8 of them are smoking. So for that reason, a clinic had been established in the primary health care. I'll leave the detail to our colleague in the coming presentation. Established 2023, targeting virtual and clinical visit at all the primary health care cluster. So if you see this figure, just to emphasize on the preventive importance of the preventive measures, early diagnosis of 70 to 90% of patients with COPD are undiagnosed worldwide. 40% are active smoker. If you see the figure, the dotted, if you start with the dark blue line, you see the severity of the lung reduction. So those numbers on a horizontal line reflect the age, and in the vertical line reflect the forced expiratory volume in percentage. So those susceptible smoker in the blue line, they have, if we notice, rapid deterioration of the pulmonary function test. If we see those who never smoked in the dotted red line, still maintain their pulmonary function test. There is some reduction, which is fine. This is attributed to the age, not because of any other pathology. And if you see the striking here finding, those who quit smoking, in the green line, you see the initial deterioration, then slowly plateauing of their pulmonary function. That's why we always emphasize on this strategy. So this is a worldwide suggested approach by screening for chronic obstructive pulmonary disease. We either have the active finding involves proactively searching for a patient who is prone to develop chronic obstructive pulmonary disease. Usually those who have typical symptom, more than 20 back year history of smoking, which is the same thing followed in the initial algorithm we have mentioned regarding the COPD. The other one, which usually this approach is in the tertiary hospital when the patient presented for another reason and they get screened for COPD. Lastly, it's needless to emphasize on the importance of vaccination, which is which can be normally given in primary healthcare centers, and furthermore, we are arranging vaccination campaign in public places for influenza, etc. But this data I obtained from the Saudi Thoracic Society, it shows us what's the reduction rate of exacerbation of vaccination. So if you see for example, influenza vaccine alone, you have a 70% reduction in the exacerbation rate, those who have underlying lung disease. Also, it has a 59% reduction in pneumonia, and admission rate 58. If you see also pneumococcal vaccination, which has a special criteria for a patient with underlying lung disease, but also it has a nearly 50% reduction rate on the admission and exacerbation. Combined together, we are approaching 70% reduction rate. So lastly, in summary, needless to emphasize on importance of quitting smoking. We exercise regularly, maintain a healthy diet, we get annual checkup as per guideline, stay up to date with vaccination, and avoid indoor-outdoor pollution, and maintain good hygiene. Get screened for lung cancer, that as per the guideline. By that, I conclude.
Thank you, Dr. Amjad, for this is amazing presentation, and you emphasize about the percentage and numbers, and some studies participate in our session. Now will be moved to fourth speaker, sorry, Dr. Abdullah Al-Khalaf is a family medicine consultant. Dr. Al-Khalaf get the diploma from American College of Lifestyle Medicine and working now with the Keepwell system under Saudi model of care at Hail Health Cluster. Dr. Al-Khalaf will be present the lecture about the Keepwell system, about enhancing lifestyle and longevity in the Hail Health Cluster. Welcome with me for Dr. Al-Khalaf.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning. Thank you, Dr. Muhammad. Thank you for the scientific committee for giving me the chance to share with you our vision in Keepwell system in the Saudi model of care, Hail Health Cluster. What have we done? What are we planning to do, inshallah, in the future? How we integrate lifestyle medicine in the Saudi model of care. Keepwell system is another definition of lifestyle medicine. How to integrate lifestyle medicine in every aspect, in every way we can. We chase our beneficiaries, every age group, in every setting, so we can keep them well. This is our beautiful flower in the Saudi model of care. Keepwell system is the first step in every pathway in this beautiful, colorful flower. Dr. Amjad and Dr. Ibrahim and Dr. Mashari shared with you some of the pathways we work in the model of care. And you notice that the first step is awareness to empower individuals and a community. These are the first levels or the first two layers of medical services we provide in the Saudi model of care, and it involved the Keepwell system, and it is its main rule. Keepwell system, as you noticed in the top right, the system will support people to stay well. We want to keep the people well before they get disease, and if they get disease, we try to regain their wellness before it will be complicated. And we saw the impact of non-communicable diseases on our infrastructure, in our healthcare providers, in our budget also, from the presentations introduced by Dr. Ibrahim and Dr. Amjad as an example of non-communicable diseases that impact our communities. A lot of key components of Keepwell system. We focus on some important rules, preventive services, lifestyle medicine integration, community empowerment also, and primary healthcare integration. So before the primary healthcare, we try to empower our communities and our individuals, so they have the evidence-based knowledge. They have the access to the services and they know how to reach it and when. A lot of initiatives launched by the Keepwell system and Saudi model of care, and all serve the main purpose, which is to keep the people well. Health coach program, community health promotion program, workplace promotion program, school and health eating promotion program, education through entertainment, population health promotion. As you noticed, we try to chase our individuals in every setting, in every way we can. Even we involve the edutainment, entertainment for our admitted children in the hospitals and also the admitted adults, so we can deliver our message in a way that is acceptable by every and each beneficiary. These are our programs and a short definition. One of the most important program, and we are proud to talk about. We reached a lot of our goals and we exceed the national targets. It's the health coach program. We now have more than 41 trained health coach program, and inshallah by the end of 2025 we will have more than 50 trained health coach distributed around the PHCs in Hail city and the periphery PHCs. Also, we work in different sectors and sections in the health services. We try to cover every corner that we can reach to serve our beneficiaries. Workplace wellness program also, and school wellness program. And after Dr. Amjad talked about the COPD and the impact of smoking, we are focusing on smoking cessation. We developed a lot of strategies to try to control this risk factor to prevent the complication of smoking by developing programs and initiating the virtual and clinical services. Health edutainment programs, as I talked about before, we try to apply it not only for the children admitted in our hospitals, but also to the adults. And alhamdulillah, we have reached the national target and exceeded. We have now, the national target is 50% of the children admitted in the hospital and 10% of our adult inpatients. With the efforts of our colleagues in those hospitals, alhamdulillah, we are reaching our targets and goals. These programs are mainly integrated in the primary health care, so we can make the access to these services easy for the patients. Every patient can benefit from these programs and clinics by just a few steps from their homes, or even from their phones. They can book an appointment virtually in the PHC with their team and they can benefit from these services, either to visit their family medicine physician or their health coach to get the service they require. I'm going to share some of the achievements we achieved in the first half of 2025. Alhamdulillah, we exceed the national targets, and this is evidence that not the حائل Health Cluster or the Ministry of Health only are working to serve this purpose, but we noticed that even the community and individuals are eager to participate. Just we opened the door and the crowd pushed in. You noticed last night the community involvement in the activities outside, and they really want to change. They know the importance of lifestyle medicine, how to protect themselves and their beloved, their families from this burden of the chronic and non-communicable diseases. These are just to show you the great achievements we, alhamdulillah, achieved in the Cape Well system. I'm going to stop here and talk about the community empowerment program. It is kindly a new project, a new program, a new target for us in 2025. We try to create better, healthier communities. We faced a lot of challenges reaching some of the populations. Some people do not listen to their physicians or healthcare providers as they listen to their neighbors or their family members or their friends. So we try to involve the community with us to be our arm to reach for the or reach the population. And 12 PHC around Hail City, distributed on every direction, nominated, and each PHC have elected around 10 persons to participate in these teams. Some of the teams, mashallah, exceed 10 persons, and they conduct a lot of community awareness programs. They try to reach their families, their استراحات. حتى احنا قلنا لهم sorry for talking in Arabic, بس قلنا لهم حتى باستراحات الشباب خلوا نستفيد من الجلسة. This community empowerment team should have their role and apply it in their picnics, in their with their friends, with their families, and friends gathering. Alhamdulillah, we have noticed a success of these projects, and those teams were amazing. They participated very well with us and reached beyond what we can in a short period. About 30,000 individual benefit and was reached by those teams. طيب. Just to conclude, Alhamdulillah, we are working in the right way in the Keep Well system, Saudi model of care. We are evolving. We are noticing development. We are noticing that people are involving with us, participating in the decision making, and that was noticed in the what we reached, what we talked about, what the Minister of Health yesterday announced, that Hail was the first city to reach 83.5 years. That is not only the physician's role or the healthcare provider's role, but also the collaboration of the community also with the healthcare system to reach these amazing goals. This is what I prepared. I hope it was enjoyable and add some knowledge to the audience. Thank you, everyone. Assalamu alaikum.
Thank you again, Dr. Abdullah. And really, there is optimistic morning with good initiatives and also good numbers. Dr. Abdullah shared it with us today. Again, I will announce about the QR code about your questions on the sides of the screen, and also evaluation. Also the QR code about the dialogue session. You can just screen it. Now we'll be moved to the last lecture in our session. This is from the burden to the breakthrough, lifestyle medicine and evolution of chronic care pathway by Dr. Marwa Mahmoud Husni. Dr. Marwa is a chronic care lead, model of care of Hail Health Cluster, and Dr. Marwa certified for International Board of Lifestyle Medicine, and Dr. Marwa is a consultant family medicine. Welcome with me for Dr. Marwa.
Thank you so much, Dr. Muhammad. Before I start, I want to thank the organizing committee for the invitation to be among you today for the second year. Today, I will talk about the chronic system of care. My colleague give you a full explanation about the pathway, what are they, but I will give you a holistic and summarized vision about what we are doing actually in chronic system of care. So if you are talking about the lifestyle medicine, so we consider the Saudi model of care as a lifestyle of medicine. It transforms just the shape and quality of provided healthcare services. How we can imagine ourselves as we grow up. We will talk about this later, but keep it in your mind. At the beginning of 21st century, the health system of care has undergone a huge transformation from reactive, episodic care to holistic, to reactive, and person-centered system of care. And the new model of care is considered as the heart of this transformation. One of the system of care included in the new model of care is the chronic care. And as you know, the chronic disease is considered as a huge burden. About the 70% of global mortality is from chronic disease. So the need of preventive, persistent, and integrated care has never been greater. Our pathway
are considered a living systems. They are not static protocols, so we can modify them and upgrade them according to the available data, feedback, and the need for evolution. The chronic system of care is the system of care dealing with people with chronic conditions. So we are no more longer deal with patients. We are dealing with population. Either of those population are healthy one, the one who has risk factor, people with chronic condition, or even the people who have comorbidities, complication, and disabilities. We have designed and implemented 15 pathways. They cover the 3 aspects of health. So regarding the biological aspect, we have 10 pathways, cover 9 disease, and the last one is sub-pathway for diabetic food. Regarding the psychological aspect, we have 4 mental health disorder, depression, anxiety, addiction, and substance abuse, and our youngest baby, autism pathway. And regarding the social aspect, we have domestic violence pathway. So what are those pathways looks like? My colleague explained the pathways, but I will highlight a few points. Our pathway is considered as closed loop. So we begin with the community level, as Dr. Abdullah said, the Keep Well system of care, take the lead regarding that with health education initiatives, and we cooperate in mass screening so we can early detect the population at high-risk group. Then the primary care level, so the levels of care not more started with the primary care, they are started with community level. When we empower the population, and that's the core value of new model of care. Second level is primary healthcare level, where the screening, early detection, confirmation of diagnosis, and even further assessment are happened, and then the management protocol. In the management protocol, we adding a lifestyle modification as an essential part of the management protocol. And to have that, we change the providing of healthcare from one person or the physician only to multidisciplinary team, which include health coaching, dietitian, and even subspecialties when required. If the patient is controlled, he remains follow-up visits inside the primary health care or even back to the community through virtual consultation. If he is uncontrolled or need further investigation, assessment, or consultation, he will transfer to the next level of care. We set it a special criteria for referral for each chronic disease to prevent the overload and waiting list in secondary and tertiary healthcare level. And once again, when the patient is controlled at the next levels of care, he will refer back to the primary healthcare with discharge summary and future plan of care. So integrating the lifestyle medicine into a chronic care system transforms them from disease management tool to health restoration engine. We had a multiple level synergy between the chronic care and lifestyle medicine. So while we focus on systemic coordination, we also focus on root cause reversal. And also my colleague will present an amazing lecture about that, so I will keep the details for him. So we can have a holistic care. When we design clinical protocols, the most important one is focus on behavioral change so we can empower our patient or person in the community. When we're setting our KPI to maintain the utilization of service, we most focus on the KPI who are meant by measure the biomarker and quality of life so we can measure the outcomes. And also we know we can't improve what we can't measure. So we track our work and progress through those KPI. And when we transform the providing services from one-man show to multidisciplinary team. We involve our doctors who are certified in lifestyle medicine and train his coach. And we have multiple physicians certified in lifestyle medicine, so we can get the most benefit in the management protocol. The conference slogan is Live 80. And according to Healthcare Authority, at 2022, حائل came at the first among different Saudi regions by an average lifespan of 81. But yesterday, we have another record that the average lifespan for the high population become an 83.5. This is our picture. Come again. So it's only about the age, or we need to give a huge attention to the quality of life. So we are now thinking beyond the early detection and the number of screened persons. We are now concerning about the quality of life, how to make those patients as healthy as we can. And through our journey from 2022 to 2025, we have increased the number of control level for diabetes and hypertension. We have now 62 control level for diabetes among the patients at the primary care level. And yesterday, we have a control level for hypertension as 72, not 71, comparing with 64 the last year and 40% at 2024 for diabetes. Also here you can see the admission rate by different diagnoses. So from 2022 again to 2025, we have a huge reduction in admission rate by different diagnoses by the total reduction calculated by 55.6%. And again, for the ER visit, we have a total reduction estimated by 59.4%, and this is for the different diagnoses. The relative admission rate from ER visit, you will find here two groups of diagnosis. The first group with high emergency group, which included diabetic ketoacidosis, hypoglycemic coma, COPD exacerbation attack, and renal failure. Those are the ones mostly required ICU admission, and you will find a reduction from 2022 to 2025. And the other group is a group which less severe and mostly required an inpatient admission. You will find here increase in the admission rate from ER, and that reflecting the ones who came to ER are the ones who really need admission, no more cold cases at ER level. Regarding the admission rate from OBD, also you will find dramatic decrease in the admission rate from OBD for diabetes, estimated by 71%, 27 for mental disorders, 75 for hypertension, and about 30% for lower respiratory disease. Regarding sub-pathway, we have a success story in diabetic food pathway. So we transformed the service from one clinic to accredited diabetic food center run by multidisciplinary team. We included dietitian, health coach, and even lifestyle medicine in the multidisciplinary team. So we had here a reduction comparing 2024 with 2025 at all level of amputation, with the total reduction of amputation estimated by 71%. Also, we have a reduction in ER-attended diabetic foot patients by 71%, and this is because we add the interventional radiology services for diabetic patients, so we have dramatic increase in interventional radiology processed by 550%, which actually save many patients from amputation. So my conclusion, when we embedded the intervention and lifestyle medicine into the management care, so we transfer the services from managing disease to restoring vitality, from fragmented to holistic, and from reactive to proactive. Let's not merely treat the chronic condition, let's transform it. And as a conclusion, Blue Zone's Hail is coming.
Thank you, Dr. Marwa, for this optimistic stories in Hail. Now, just please, for all the speakers, can we please coming to the stage for starting the panel discussion. Dr. Mushari and Dr. Ibrahim, Dr. Amjad, Dr. Marwa. Okay. Now we'll be starting our discussion. Thank you for all the speakers. Really, we're so proud for this model of care in Saudi Arabia. And really, we hope, inshallah, everyone get some informatives he can help you in your practice. Now I will starting with Dr. Mushari. I have a question about where does primary care fit into the Saudi model of care?
Thank you, Dr. Muhammad. You ask about the primary care fit for the new model of care. Actually, we have 109 primary health care in High region. In this all primary health care, we applying the new model of care pathways. We starting from 2021 about the new model of care, and we have the completing now almost 5 years on applying the new model of care in primary care and multi-system. We have in a chronic disease more than 6 pathway. It's a national pathway, and also for the different system of care, we applying this pathway for all the 109 primary health care in Hail.
Thank you, Dr. Mushari. Now I will remove for Dr. Ibrahim and Abdul Qadir. Also, there is some question about the. Can you please explain a lot of challenges facing you when starting your unit? Especially, I remember in 2024, we're starting this unit in Kingston Man Specialist Hospital. Just can you explain to us about your challenges?
First, I will thank Dr. Muhammad. He's support man for our vision. Actually, we have big jump from nephrology care from before to now. this jump, not I mentioned before, not one-man show. It is multidisciplinary team. Started from high level of executive. After that, from the administration, medical director, and the other department, because we work as a multidisciplinary team, not only for nephrology. For example, we can't work without another team. Like for renal biopsy, we need IR, we need pathology. For start the BD, implement and improve the number, we need GS team. For vascular, we need vascular team. So our challenges, actually not challenge, but we have a new idea and a new thing we can do. Our challenge is how we can get the approval, and always we can get approval easy because we have a vision. The vision, it is for everyone, I mean, from our services and the other services. So actually no more challenges. Maybe there is some challenges for the staff, but no, now all the staff trained for nephro care and kidney care. So the challenges, it is how we can start. The starter, it is our challenges. After that, we can go deep for our idea or our vision.
Thank you, Dr. Ibrahim. Now I will move to Dr. Amjad about the services of the Palmo in Hail. Can you please tell us about what is the next, what is your plan, inshallah, in Hail Health Cluster about the services of the Palmo in Hail region?
So as I shown in the presentation, since you are here discussing lifestyle and aerial preventive measures, we have an integrated care with our colleague at the level of Hail Health Cluster in the primary health care to make sure we have clear pathways and clear referral system, and also not only to focus on the secondary or preventive tertiary care, but rather to optimize the activity at the community level, which I think it is obvious the healthcare cluster are doing a great job with the evolution of these awareness days, activities, campaign, and also just to have the work system organized and focused, especially in a common disease from a pulmonary point of view that is associated with other cardiovascular system, nephrology, etc., other disease. That's at the primary care and preventive measure. In terms of pulmonary service at the level of Hail city, we are expanding the advancement of the pulmonary service. We, in King Salman as tertiary center, which is led by you, Dr. Muhammad, we have established advanced intervention. We have this year, June, accreditation for sleep centers. We also had a full working bronchoscopy unit, and also that not only in King Salman, but in King Khalid Hospital, we have full working bronchoscopy unit. A few weeks ago, we have established interstitial lung disease service, so we have a newly joining ILD consultant. We are providing antifibrotic and advanced treatment for those patients. We also, for asthma, if they came, unfortunately, in an advanced case, we do provide biologic treatment in King Salman Hospital. Hopefully, we, of course, improvement is continuous for the future.
Thank you, Dr. Amjad. Again, there is also a question for you about the relationship between the physical activity and reducing the risk of COPD, and also about the air quality and relationship with the asthma. Just you can tell us, is there any impact about this one?
So, of course, we always encourage physical activity regardless of what's the underlying condition. Always, physical activity is it's a proven in moderate exercise, let's say. In COPD patient, exercise capacity is also encouraged, but at the level of the personal tolerance rather than strenuous exercise is preferably to be avoided. That is always advised in the COPD patients. For the second question, asthma and the quality of life, I should emphasize also again on now we have emerging subtype of bronchial asthma, advancement, what type of asthma, neutrophilic or eosinophilic. But however, we go back to the initial phase, early treatment, earlier diagnosis, earlier treatment, and most importantly, addressing risk factor in bronchial asthma is a key factor like obesity, gastroesophageal reflux disease, rhinitis, etc. That I have mentioned in the algorithm there to address a risk factor at the initial phase.
Okay, thank you, Doctor. Now I will move to Dr. Abdullah about the, we saw a lot of initiatives. I think all of them needed in the system of the health. Can you please, do we need more details about your initiatives and what is the plan in 2026?
يعطيك العافية دكتور. Actually, as you said, Doctor, we have a lot of initiatives, but some are kindly new, as we talked about, the community empowerment, and we are still focusing on the health coach program. Health edutainment is new emergent project, and it's unique. We deliver our project or the idea to those hospital with admitted patients, either children or adults, and they were creative. They, mashallah, create a lot of interesting programs to entertain and educate the patient at the same time. The patients who are admitted, their condition is not, they're not ready to accept or tolerate someone to give them a dry information. They need a way, a creative way to make this information absorbable by those patients, and we can deliver the our aim in a creative way. So we deliver our program. We talked with our colleagues in those hospitals, and صراحة they were amazing, creating a lot of projects, either for the children and also for the adults. Community empowerment program, we are inshallah planning to expand. We are now having 12 teams distributed in حائل city. Our aim is to involve all the PHCs in حائل and the peripheries. The target for the next year, inshallah, to at least cover the 29 PHC in حائل city, to reach all the populations in their PHCs and in their neighbors.
Thank you, Dr. Abdullah. Now I will move to Dr. Marwa. I have a question for really in your presentation. We so happy and so proud for this amazing achievement. And now regarding of the my question, I have questions also. There is a question from the audience about how we can generate this amazing experience in all over the KSA. And also, what about, I think the study, it can help us also to be publish amazing number, to be help also submit our experience to the world.
Thank you, Dr. Muhammad. Actually, we were thinking about that. We found we had a huge achievement over the past years, and this achievement needed to be published so the whole world can get benefit from our success story and what we done here in Hail, especially with the accompaniment of those achievements with a huge documentation that we have really now the longest life expectancy among the Kingdom of Saudi Arabia. So we are now taking those achievements to the next level. We will get or prepare paper to be published. Also, we have a network for chronic disease among the whole the kingdom. So every success story, every achievement will documented by the region. So Hail's achievement will be documented to Hail, and this we will transfer our success story and our experience to the other regions of kingdom. So we can get them what we actually did and what we did good, not only that, and we can get the most benefit from each other one experiences. So I hope this answers your question.
Okay, thank you, Dr. Marwan. Thank you for all the speakers. I think we reached. And also, I think there is a time for.
Now we would not just listening to great speaker, we will be also able to ask your questions and evaluate the lecture through the QR code, and could join 80-second workstations, take a part and pick one of dialogue session, meet Mr. Aja, our interactive AI avatar, and explore many other activities to bring lifestyle medicine to life. At this time, we would like to invite our designated speakers and session moderator on stage to may recognize and honor their valuable contributions. Welcome. Thank you, our moderator, Dr. Muhammad Al-Zayed.
Abdullah. Good morning, Abdullah. Do you know that most chronic diseases do not appear overnight? They build up from years of habits. And what are the good news? Healthy habits build up the same way.
Good morning to you, Abdul Majid. And good morning to you, our beautiful audience. And I will start to ask a question to you. What's one small habit you would start to change, to improve, and also protect your long-term health with?
We will explore that with our next session moderator, Dr. Amjad At-Talla', consultant of pulmonology and internal medicine, and head of the pulmonology unit at King Salman Specialist Hospital in Ha'il. Please welcome Dr. Amjad.
So thank you for the introduction. We will move now to the second session of the second day. We will discuss the public health and preventive measures. Before I start with our first speaker, I should emphasize on QR code on both sides of the screen. If you have any questions, you kindly screen it. We will keep the question at the end of the session. First presentation, we will be presented by Dr. Latokumbo Sungwawa. He's a consultant public health with a fellowship of public health from West African College of Physician and Master of Public Health. Dr. Sungwawa will be speaking about lifestyle medicine, public health, and longevity. Are they parallel track or branches of the same tree? Dr. Sungwawa. Good morning.
Hello, good morning.
Welcome in our meeting, Dr. Sungwawa. So without further ado, floor is yours.
Thank you very much. I think there is some adjustment. This is going to be a dual act, and my colleague, Professor Edward Kununga, is also on the call, so we'll both be doing a dual act, presenting and looking at the lifestyle medicine, longevity science, and public health, and asking the question, are these three sides of the same coin or different tracks? So we should be hoping to exploring links and differences between these ones. And the outline of the presentation will be looking at, so we'll look at introduction, try and give a brief overview of the definitions and concepts, look at overlaps and synergies where there are distinct foci and tensions, and then we'll dwell a bit on integration in practice, policy, education, and research imperatives. And then we'll end up looking at call to action. I'll be setting the scene, and while my colleague, Professor Edward Kununga, will be looking at the main content and taking us through the different overlaps and integration in practice. And we then end up looking at the conclusions and call to action. Next slide, please. And those are my declarations. And because of time, it's just to put that up. And the next slide is my colleagues' declarations. And just as you've seen, it's a son of Hail. Is based with you in Saudi Arabia. So really, as introduction, we'll a brief look at the global health context, and then going ahead to frame the question. As we all know, chronic diseases, excuse me, also known as non-communicable disease, account for about 71%, over 70% of global deaths annually. and that makes them a dominant public health challenge. These conditions, as we know, that includes cardiovascular disease, diabetes, and cancer. They are largely preventable, and they share common risk factors, some of them which we have heard have been since the beginning of the conference, such as poor diet, physical inactivity, tobacco use, and excessive alcohol consumption. But at the same time, and I was interested to hear from Dr. Mawa's last presentation, population aging, we've had unprecedented increases in life expectancy. And just as she mentioned, I think the life expectancy in Hail is now the largest in Saudi Arabia. But the key question is these added years, they're not always added, they're not always lived in good health. So the concept of health span comes up, which is the number of years lived in good health. And this is now come up as emerged as a critical metric alongside lifespan. Currently, people spend an average about nearly a decade averagely living with chronic diseases or disability. And that highlights a gap that needs urgent attention. So this presentation actually frames the central question: are lifestyle medicine, longevity science, and public health, are the three sides of the same coin, working synergistically towards a common goal, or are they distinct tracks with separate priorities? Understanding this relationship is essential for shaping future health and healthcare strategies that are proactive, preventive, and equitable. So we just quickly go through the definition of, just let's remind ourselves of the core concepts, which I'm sure we're all quite familiar with. Lifestyle medicine, which is the whole purpose of this conference, as we know, is evidence-based clinical discipline, applying therapeutic lifestyle interventions to prevent, treat, and often reverse chronic diseases. We are quite aware of the 6 interconnected pillars, which actually has been raised, and that's looking at nutrition, physical activity, sleep, stress management, avoidance of risky substances, and their positive social connections. And longevity science, sometimes referred to as longevity medicine, that one aims to extend both lifespan and health span by targeting biological aging processes. And this incorporates advanced diagnoses such as epigenetic testing and so on, including nicotinamide adenine diclonitide infusions, which are essential molecules found in every cell that are necessary for bodies to function. And public health, on the other hand, operates at population level, emphasizing disease prevention, health promotion, and equity through policy, environmental interventions, and community programs. So while lifestyle medicine and longevity science often focus on individual interventions, public health addresses systemic determinants of health, making it indispensable for large-scale impact if we're going to have that. And as such, these definitions now set the stage for exploring overlaps, synergies, and tensions, if there are any, amongst these three domains. I'll now hand over to my colleague to take us through the next slides.
That's great. Thank you, Dr. Tox, and good morning, colleagues. Greetings from Tabuk. I'm based a little bit south of you and would have loved to be with you in person, maybe next time. So as already been highlighted, we are trying to explore whether lifestyle medicine longevity science and public health are part of the same coin. Now, here are some of the areas where there is commonality in all those three areas. And I think we have to be very careful that we don't invest too much energy in what might separate these domains, but we should think about how do we align them, because they're the fundamental part of this is the common mission, which is about adding more years to life and more life to years. How do we prevent chronic diseases? Dr. Talks has already highlighted the burden of disease impacting all populations globally. And how do we harness all of these as tools in our armory to make a difference? We also know that even longevity science recognizes the fundamental basis of those interventions at a molecular level are supported by the lifestyle interventions. You can't have a micro level intervention without building on these lifestyle interventions. And perhaps referring to them as pillars is appropriate because it highlights that all these advancements cannot stand on their own and they need support from the pillars. But then I would like to propose that public health provides the foundations, that even the pillars would require these foundations without which they too cannot stand. The environment where people make their decisions, the conditions in which they live their lives, the affordability, the access, the availability, and some of the barriers that might get in the way of people participating in these interventions, even if they know what the evidence base says. So we need a more synergistic approach to how we address this, with public health providing you with the foundation, lifestyle medicine providing you with the pillars, and then longevity science giving you perhaps what I might call the targeted, precise ways of intervening. But we also need to recognize that not everyone can afford some of the multi-omic testing. And even if we could afford, we couldn't roll these out at a population level. So we really need to think about how do we improve the lives of populations. There are differences in scope, there are differences in the tools that are used, and the differences in the evidence base. There is a difference in the level at which you're intervening, with longevity science looking at intervening at a micro level, cellular level, and building up on some of the understanding of biomarkers to really target regenerative therapies and precision medicine, precision nutrition, precision and predictive prevention. Lifestyle medicine looks at holistically on the individual and in many cases, families and supporting communities. And public health targets at a population level, and how do we ensure that our policies align so that we don't give people the information that they cannot utilize because of the many different barriers, whether they are environmental barriers, whether they are about affordability, access, health literacy. All of those are really important if lifestyle medicine is going to make a difference to the population health challenges. And I draw comparisons with the epidemiological transition that we have experienced. When we had the big burden being communicable diseases, it wasn't just down to pharmacological or pharmaceutical interventions. We also needed improvements in environments. We also needed advances in antibiotic treatments, and none of them in isolation led to the decline in communicable diseases. And perhaps as we face the big challenge that we have of non-communicable diseases, we need to think and reflect on how far we have come and how we need to align and integrate all these different interventions if we are to make a big difference on individual health, community health, population health, and global health widely. So we do know there are many examples, and some of them have been shared here already. We've got local examples here in Saudi Arabia of integration of health interventions with public health interventions and also longevity science. We've all heard about the blue zones. I was delighted that Dr. Mara talked about Hail being another blue zone, and bring it on. It's about time that we celebrate the successes that are happening within the kingdom. But of concern is the growth in clinical longevity programs. I think as a society, as a profession, we need to ensure that we don't see a proliferation of programs that are promising without the evidence base. So how do we build, how do we ensure that we provide the foundations that are critical? How do we ensure that our pillars stand on solid ground? And how do we ensure that longevity programs align with the evidence base and we build collaborations rather than becoming competitive? How do we align clinicians, researchers, policymakers to make a difference? And all of this requires transformation at a policy level. And here in the Kingdom of Saudi Arabia, we've got the Vision 2030, which is doing exactly that. We've got a Healthy Cities program with 16 cities accredited as healthy cities using the WHO definition here in Saudi Arabia. I work as the Director of Public Health at NEOM, where we are trying to build for the future and build in health in all policies, digital innovations, as well as advances in predictive precision prevention. We also need to look at educational reforms. How do we get in the training of current and future generation of clinicians and policymakers so they get that these are all sides of the same coin? How do we ensure that our research focuses on the critical areas and absolutely shift the paradigm of healthcare from the traditional reactive disease-centered approaches to much more holistic approaches that are more predictive, that are more looking at how we enhance health span, and also that are incentivized and provide adequate resources. So hopefully that gives an idea on whether these three disciplines are separate or whether they are three sides of the same coin. And yes, coins do have three sides. If you look very carefully, you will see that there is the side in the middle that is also a side of the coin. So we will propose that these three areas are not in competition, but together, if collaborated, if integrated, can lead to differences in individual health, community health, population health, and fundamentally global health. And Dr. Talks will do the conclusion and the call to action.
Yes, you are muted, Doctor. You are muted.
Sorry, it's just playing up there. Yes, sorry, apologies for that. Yeah, so we're ending up now proposing that we have this opportunity here now for unified mission for health and longevity. As my colleague is taking us through that, the convergence of lifestyle medicine, longevity science, and public health offers a transformative opportunity for us to redefine healthcare and health systems. And just as Edward had said, rather than view these disciplines as separate tracks, if we go ahead moving forward to be seen as complementary components of a unified mission, so that we can properly align lifespan and health span, so that we build on the successes we made in improving life expectancy, but then building a health span to it, and ensure that there is no inequity and look at all the ethical considerations. So we're proposing that achieving this goal requires collaboration, and I remember Edward mentioned, across clinical practice, research, and policy, as well as a commitment, which I think is key, which you're trying to stress, that a commitment to equity and sustainability. We're proposing that clinicians must integrate lifestyle counseling with emerging longevity interventions, while public health systems create environments that support healthy behaviors. Excuse me. Policymakers should incentivize preventive care and fund research that bridges individual and population level strategies. So ultimately, the future of health depends on our ability to harmonize these approaches into a coherent framework that prioritizes well-being over disease management and prevents institution of vertical programs, which may then only be accessed by people who can afford it. So what we say now, we're calling on all stakeholders to embrace this integrated vision and work collectively towards a healthier, long-lived global population. Thank you.
Thank you, Dr. Sangoawa, for this comprehensive talk regarding the public health. I will allow the audience for a few questions if we have. Any questions? So thank you, Dr. Sangoawa, again for this nice presentation. We will move now to the second presentation by Mr. Tariq Al-Abdul Wahab. He's a public health program specialist and supervisor of the Healthy Settings program. Be speaking about Healthy Settings program towards a better opportunity to promote a healthier lifestyle in the Kingdom of Saudi Arabia.
السلام عليكم ورحمة الله وبركاته. So, first of all, good morning. It's an honor to stand before you. I see an expert for the public health, and they said that we are late, so I'm trying to be on time. So today I'm going to introduce to you about the Healthy Setting program. But before I talk more about these programs, I want to talk to you about the Saudi Public Health Authority. It's an entity that works for the public health in Saudi Arabia. The main goal is to promote healthy lifestyle and also protect the population's health. Our vision is that around the clock, we protect and improve the public health and enhance the health security through national interventions and design, implement, and evaluate the interventions that's related to public health. And in our strategy that it's in this year, the first strategy for public health authority, but next year we have another round of the strategy 2. But this strategy stands for 3 pillars, which is inform the public health landscape for the kingdom, also protect and improve the population health through designing, implementing, and evaluation the interventions. And as you can see, object number 8 is public health authority is working with different entities and stakeholders, because we are not a full executive entity. We have to implement interventions with our stakeholders inside and outside of the health ecosystem in Saudi Arabia. So why do we focus on promoting healthy lifestyle on different settings? So around 22,000 Saudi die each year. And that's around 35% of the total death in Saudi Arabia caused by the NCD's mortality. And it's also caused the country around 3.8% of the kingdom GDP. So this is an important issue that we have to focus on, the mortality rate in Saudi Arabia, and also the cost that comes for economical and social in Saudi Arabia. So here it comes to the importance of designing an interventions and national program to promote healthy lifestyle on different settings. And that's what it comes to the healthy setting program, which focusing on designing interventions in different settings such as school, universities, and workplace. So the program aims to promote lifestyle and health-related behaviors such as physical activity, nutrition, anti-smoking, sleep, and psychological status by providing a range of interventions such as guidelines, initiatives, incentives, and enable places to administration to create healthy settings by adopting a healthy lifestyle. The program also seeks to develop the physical environment in addition to promote healthy lifestyle through other behavioral factors for the schools, universities, or workplaces, and many settings. So the program is aligned with the Vision 2030. One of the objective goals for the Vision 2030 is that the kingdom has a vibrant society, community through the quality of life programs and the health sector transformation program. And also it's aligned with the sustainable development goals, goal number 3, which is good health and well-being. And also it's aligned with the WHO community health promoting framework, which adapting and implementing the 4 components of the framework. And also it's aligned with the health policies for all, and by reducing the burden disease and also reducing the life, increasing the life expectancy by reducing the chronic deaths and their risk factors. And as well aligned with the Saudi Public Health Authority strategy, which is Objective 3 and Objective 8. So each sitting, let's take for example the school healthy setting. The healthy school settings. It goes to 4 different phases. Phase number 1, which is as you can see, designing, and then we design many interventions such as guidelines, training programs for teachers, and also implement the interventions itself in line with the Ministry of Education. And also, after we implement it, we have to evaluate. But before that, absolutely, we do the pre and post assessment for each interventions to see which interventions worked or not. So we have 8 sittings, as you can see. This year we launched 2 sittings, which is health schools and healthy universities. And as you can see, we will do the launching until 2029. But keep in mind, this is the timeline for us, but already we launched many sittings because it's ready to go, and also the stakeholders, which is the owners of the sittings, are working together with the Saudi Public Health Authority, and they are offering support and help to implement the interventions that we design and implemented with them. what are the outcomes of these programs. We do guidelines, digital solutions. We do training packages and also awareness campaigns. And most important, that we give accreditations to schools who implemented and meet the criteria that we designed for them. And also we do implement and designing policies for the schools, university, and other settings. And this is the visual identity for the statistics programs, and also the certificates that we give to schools. And this is the signs that we give to the winner for the programs. If you have any questions, please email us. Or if you are interested to be a part of these programs, we are here to work and to collaborate. Thank you so much.
Thank you, Mr. Tariq, for elaborating more in a practical step toward promoting the public health. Now we will move to our third speaker, Ms. Sana Al-Sadra, HIV National Coordinator in Khobar City with a PhD research in the field of infectious disease, Imperial College of London, to speak about the impact of lifestyle pattern on the prevalence of sexually transmitted infection.
Hello, good morning, everyone. I will introduce myself, Sana Al-Sadra from Khobar City, work in preventive medicine, coordinator of HIV program and STI. Maybe you have a question, what is the relation between lifestyle and STI? Okay, and STI prevalence. We will find the answer within this presentation. Here, can we see this most common pathogen for sexual transmitted diseases in Saudi Arabia? First one, the non-gonococcal urethritis. The second, trichomoniasis and gonorrhea. Gonorrhea, we have very big prevalence in this year, and syphilis also very sensitive and increased the last 2 years. HIV, unfortunately, HIV globally decreased, but maybe in our Arab countries and in my country, increase is still very few, but it is increased because the lack of awareness. Then the genital warts and herpes, the last thing. Here in this slide, some meta-analysis studies, but the most important, the first row, here about the women in Saudi Arabia. They screened for human papilloma virus and the ratio was 14.9. So as you know, now we have campaign in all schools in Saudi Arabia to do the vaccine for girls from, I think, the age from 15. Okay. As I mentioned, unfortunately, the HIV increased, the syphilis increased, gonorrhea also increased. Chlamydia also, but chlamydia, we noticed that there is a miss reported in Hassan. Hassan, it is the governmental portal digital, but not all hospital in private or governmental sector, they record the new cases. So still our data need to work more on it to be more validity, to use it for a new policy or intervention prevention. Okay, sorry. I think here, what the Saudi Arabia government, Ministry of Health, what did for avoid increase the incidence rate about the sexual transmitted disease. Number one, the mandatory testing for in different fields. For example, people in prisons, mandatory to do some tests, blood tests, viral for HIV, hepatitis B and C, also syphilis. Prenatal for all pregnant women in the first visit for the clinic, they have to do HIV, hepatitis B, C, also syphilis. And I think also pre-employment, pre-marriage, also pre-operation. More blood investigation, we detect more cases hidden before. Okay, this is about the global burden. I will transfer for the second one. Here the data from 22 to 2025, but we have some data less than 25. As you know, some statistics still not appear for 25, but here for STI in Saudi Arabia, we have, this is global, I'm sorry. I will change to Saudi Arabia. Here, we have also the HIV, hepatitis, syphilis. We are very worried about two things, HIV and syphilis. These two things increase. And about the chlamydia, the reported, as I mentioned before, I know it may be, in fact, it's increased 20% more than what's recorded in the portal on Hassan. Okay. Here, the epidemiology by age, sex, and key groups. The infection within women or girls, it's not equal, not usually equal for the infection with men. Because our culture, the women movement and the freedom for the women is not like guys. But we will not cover our eyes. There is a relationship, and some women, they have sexual disease or infection. Every day I faced stories about girls when they receive pre-marriage results, or sometimes they want to do a blood test for pre-employment, then surprise they already infected with syphilis or HIV. And this disaster in our maybe community, not just for the girl, but for the family. For the guy, feel very stigma because he can't tell anybody, and also some companies, they refuse to employ a person affected with HIV. So the age, it's not equal. The gender here, male more than female, but it is maybe more the disadvantage or the negative part with the women more because they're pregnant and because maybe some virus like human papilloma virus will cause cancer for women. So maybe the effect is different. The target for the target people we work into more aware them from 15 until 49 or 50 above 50 a little bit. They have active sex, but they don't know where they go. Where is the counseling center and Ministry of Health? Who is the right person? Social media or website, it is not enough to give information. It is still we need to counseling one-to-one. You know, the girls, they feel very shame to ask about things like this. Before 2 years, I visit several of schools. I found the questions of the girl, they ask deeply. You know, the generation is different now, and they open and they talk about everything. not as before. So when they ask me question, I surprised about the question. I ask all the girls just to write the question on the piece of paper, because they feel more free to ask about it. But the question about different things, about oral sex, about intercourse, and they still in high school. So our lifestyle now, the freedom, the social media, the doors open everywhere. So the generation, they have freedom, this is positive, but they are not have enough awareness. List transfer for here surveillance and reporting data challenge. How we deal with this confirmatory cases. In Ministry of Health, we follow the suspected case, not confirmed case. Just when we see the suspected case, they just ask for blood test or for confirmatory test. We follow the case until the date of result of the confirmatory test. Directly for HIV within 48 hours, we have to finish this case with the person, call him or call her, finish our small investigation, transfer for the infectious disease clinic. There they will continue with him for measure CD4, also viral load.
Sorry for interrupting. You have 2 minutes just to.
Okay. I will give you briefly the link between lifestyle and prevalence of STI. Okay, number one, weakening of social bonds. Now our family is not like before. Before we interact with the extended family, grandmother, big sisters, but now the small family and the bonds become more weak. All travel, girls and boys for study or for work. In Hail, I know the Hail, it is a calm city, and they still, I think they still strict maybe culture, not like open cities. But I faced some guys come from Hail to Khubar, and we request them to do the investigation for some sexual disease. So the awareness requested in everywhere, in every city in Saudi Arabia. So the access of freedom, this recently, the last years, we have to work on awareness very hard, because the freedom now big, but our awareness is still weak. Also the rapid life, the guys don't have enough time to ask, to research, to be sure about their partner. They will travel for another country. You know, in my city, we're very near for other GCC countries. They don't have time to go for counseling, a clinic to ask what I have do, if I will maybe pressure myself to exposure myself to risk. And the last thing, it is the limited access for counseling. We need to increase the number of counseling. Now, in Al Khubar, we have in each primary healthcare center, there is counseling service to all people, Saudis, non-Saudis, female and male. No ask about his name or identity or phone number. Just give the counseling and do rapid test for him or her. If he or she want to give her name or his name, it is okay. Then if we need to do the confirmatory test again, we call him. Thank you. I hope I find something for you useful.
Thank you, Ms. Sana, for this talk. So before I move to the last speaker of this session, I should emphasize on the QR code on both sides of screen, especially the vision sessions. Kindly, you can log in there to have your time with our valuable speaker after the presentation to ask them in details. So I'll move to our last speaker, Prof. Al-Mubashir Farouk. He's a global health epidemiologist and One Health leader, member of the One Health high-level expert panel from World Health Organization, to speak about the Islamic's strategic framework for promoting health and human well-being, the case of communicable disease. Prof. Al-Mubashir.
Yes. Assalamu alaikum. Can you hear me?
Wa alaikum assalam wa rahmatullah.
Yeah,
Welcome.
thank you so much for giving me this, opportunity to speak about, communicable disease and lifestyle medicine. I guess the second speaker, they make my life easy. So I will reflect on areas related to, the history of infectious disease, from 7th century, till now. And also I will reflect on microbes and human disease. And then I will have some time to reflect on my current project in Oxford and about how Islam manages infectious disease and how we can have some lesson learned for the coming outbreaks. And also I will reflect on the philosophy of prevention using Islamic lifestyle, as well as I will reflect for you the proposed communicable disease prevention framework. So going back to the history, those gentlemen, Robert Hooke and Antonio Leeuwenhoek, when they utilize this, standard microscope, they managed to know for the first time during the 16th century, we do have some micro creature or microorganism. But later on, the leaders of the infectious disease discovery, Louis Pasteur and Robert Koch, and then the physician John Snow, we managed to know much about the causes and the germ theory, as well as for the first time, we managed to know that the organism can cause infection. Here, this is a new era of communicable disease. But let us go back to our history, to the 7th century. Do we have some, clue or evidence from the Islam about communicable disease and how the Islam prevent communicable disease? I spent 20 years in dealing with communicable disease, tropical health. I did my first PhD in communicable disease program design. I spent 8 years in dealing with HIV/AIDS program management among high-risk group. And I did my second PhD in the American infectious disease. And as a member of several committees concerning communicable disease, I ran communicable disease program for 15 years. There's a lot of questions came in my mind, specifically with the coming settings of the global health right now with withdrawal of funding, the emergencies. Is there something solid we can have from our religion? This is the basic foundation of our life and things we are doing. So this is my project here currently in Oxford, like mapping, doing in-depth analysis about hadith and ayahs, the foundation of Islam and how it's related with communicable disease. So I will spend quite time in this lovely city dealing with this, with history, using a lot of case studies, different methodologies, and combining this with the new public health interventions and tool and setting, the ground for the future. Specifically, we are speaking about almost 30% of the population, they are practicing certain kind of Islamic practices, and 2 billion Muslim as member of the OIC. So there's a lot of questions. How Islam is managing infectious disease, before, and what kind of lesson was. Going back to the time of the Prophet, here we are speaking about the 7th century, you have some cases reported of communicable diseases. There's a lot of measures. There is no, evidence concerning outbreaks during that time. You can see the settings. People, they are close to animals, traveling, dogs. They have herbal medicine. The medicine is not advanced during that time, but let us go deep. Our Prophet, he mentioned a lot of direct and indirect things which it can be related. Till now, we are calculating more 1,000 hadiths, which can have direct relation or indirect relation with tools and strategies to prevent communicable diseases. This slide I will skip because most of my presentation, it will be around this. So there's a lot of this. You can see our Prophet mentioned the sick. On the sick one should not be brought to healthy one. There's a lot of hadiths when we sneeze, and there's a lot of hadiths speak about pleurisy. What differential diagnosis. A lot of hadiths speak about the fever of Medina, measles. So covering food. There's a lot. As I mentioned, right now we have, as part of the literature, we are researching in Madi of the Sunnah books and ayahs and tafsir. There's hundreds of like this hadith. So, as matter of foundation, when Allah created us, and when Adam and Hawa came to this land, this ayah that I will mention in Arabic and then I will translate. وَمَا مِن دَابَّةٍ فِي الْأَرْضِ وَلَا طَائِرٍ يَطِيرُ بِجَنَاحَيْهِ إِلَّا أُمَمٌ أَمْثَالُكُمْ. So, microorganism, it's like a community. The species, it's like us. So we are created, we are living in this ecosystem. And in this ecosystem, part of the ecosystem, we're speaking about from micros till macros, which is shark and elephant. So I need you to concentrate with me because this is one of the golden slides. So here I use this as like theoretical, so this is like imagination. We have what we call internal, internal things in our bodies. And then we have the externals. This is, the foundation. And this will be based on the theory and the hypothesis you put. So, and then when we came also to infectious disease, new discoveries tell us that we are full of microorganisms. And then we can see when we have the genomes and nuclear medicine, we describe that, we discover that the human cells only it is 30 trillion, and the majority of our body is microorganisms, different kind of microorganisms. So also part of us, it is like, the majority of us is like gene related to organisms. So we are living in an ecosystem that's full of organisms. I need you to concentrate also with this slide. The microbiology tell us that almost 95% of the organisms, they are healthy, they are friendly. We have only 5% the animals. And the Islam use the animals, adwa. So that means we are protecting for something it can make harm. So, and this is the risk. Sanash, you mentioned HIV, but there's so many kind of communicable disease only caused by the 5%. Then you can imagine this is something crucial for our interventions and crucial for our public health strategies. So, going back to the history, we have a successful intervention, which is male circumcision. This Islam adopt male circumcision since long time, and right now, after clinical trial, male circumcision adopted as one of the global health strategy to prevent sexual transmitted infections, male HIV can prevent 60%. So this is approved and right now it's massively funded. We will speak about fasting, intermittent fasting. We have rules for this. And then this is what I'm doing right now. Mapping what we have as Muslims, it can help us, and it can be also adopted as one, adopted as public health intervention. So this is, the prevention framework. So here, the prevention framework, this is the hypothesis. Allah created us to worship Allah and then doing development in this earth. But when Allah created us with powerful protection system. And the protection system, we have what we call internal protection and external protection. And there's harmony between synergies between the internal protection and external protection. A lifestyle is part of this. So this is the theory. So we created, Allah mentioned in Quran, He created us with powerful system. He created us with immunity. الذي خلقك فسواك فعدلك وخلقنا الإنسان في أحسن تقويم. So this is the model. The internal immunity, and and the external immunity, part of the internal immunity, this is inside our body. So Islam tell us about breastfeeding, fasting is part of this, and then we have like balanced nutrition. Islam spoke about stress, sleeping, and then the mandatory and encourage us to training. And the rest, they are external training. So external immunity measures. So when it came to the external immunity, there is a lot. The 95% of the Islamic intervention is the external immunity. So I will address this. Okay, so the external immunity is like cleanliness, healthy food, like good hygiene, have environmental care, like social behavior, sexual hygiene, dealing with zoonotic disease. Those kind of things is external immunity things. But there is harmony between both internal and external immunity and interventions, because the harmony, it's like, the objective of this harmony is it will be, this equation. So the internal immunity system is to fight the germ, when they enter the body, but the external one is to decrease the dose of infection. It is to decrease the frequency of infection. Is to decrease the exposure. So those balance is so crucial. So we do those kind of things to decrease, the exposure. Because of the time, I will go to it. So here, this is the internal immunity. You can see we have the breastfeeding, which is right now one of the crucial major intervention in Islam. There's a lot of ayahs and hadiths, tell us about this. And then fasting. Fasting right now is one of the major strategy, and the fasting, it can boost the internal immunity. So this is something, and we have Ramadan, it can be one of the major area to boost the immunity, which is to help us to control communicable disease. And then stress, there's a lot of evidence right now speaking about stress and how the stress can affect the immunity. And we can go on. All of this affecting the microbiome, which is right now one of the major discoveries when it came to our immunity. So you can see this system, how it is integrated. Still, we are speaking about the internal immunity, things inside us. The external immunity, as I mentioned, the majority of Islamic intervention.
Sorry to interrupt you, but we are behind our time. Yeah, 2 minutes to wrap up.
Okay, I will finish. So when it came to external immunity, so here I can give you one example. Using of our hand, right or left. In Islam, we have rules and regulations used for which activity your right hand, and for which activity your left hand. I will let this to your imagination. But the hand itself, it has to be clean. We wash our hand in wudu and ghusl, and we wash this 15 times per day. Then you can imagine the individual and the community impact of this. This is during Salah. And then we have nose hygiene, respiratory hygiene, all of this, those kind of intervention, external activities, and then sexual hygiene, as I mentioned, male circumcision. But sometimes the internal immunity and external immunity, it will not be enough, specifically during pandemics. This is why, the Islam, mentioned going for quarantine and isolation. So this is long time ago. So as I mentioned, those kind of internal immunity and things, yes, it is micro level, but it will not work in isolation. It has to be some sort of harmony between them and some sort of integration. So this is the framework. I will close here. So this is the work. Still, we are in the early months. We will continue here for two years to map things, align things with the modern public health, and then in the end, we are aiming to have framework. Thank you so much, and I'm ready for any question. Thank you.
Thank you, Prof. Mubashir, for this interesting talk. I have one question. Do we have any one or two example for any clinical practice guideline that is obtained based on Islamic perspective?
Thank you so much. This, as I mentioned, male circumcision right now. I was part of this is long time ago. Male circumcision, they observe it can prevent sexual transmitted infections. And then they did clinical trials, several clinical trials, and then in the end, currently it's absorbed as one of the clinical and public health interventions. So you can think from theory, from philosophy, to something right now it is endorsed. So now I spoke about HIV/AIDS, and then for HIV/AIDS right now we have abstinence and condom use, as well as C, the other C, A, B, C, C. They add the C because of the circumcision. We will speak about breastfeeding, and right now you speak about sleeping, those kind of things. The Islam put the foundation for those kind of interventions, and then we need to apply this as in the clinical settings as one of the public health tools. And the beauty of Islam, it is practiced as individual level, at the community level at the same time. What we are thinking right now, Doctor, is like how to align this with the public health interventions, how to integrate and inject those kind of interventions in our lifestyle medicine, in our public health tools, because it will sustain. It will sustain, but we need this to do the consistency, and we need to practice this in quality measures.
Clear enough. Thank you again, Prof. Mubashir, for this interesting talk and touching on this topic. Thank you. So now we will move to a panel discussion. I would kindly invite Mr. Tariq and Ms. Sana to join the stage for discussion. So thank you, Mr. Tariq. Thank you, Ms. Sana, on those great talks. I'll start with Mr. Tariq first. You mentioned about promoting the health at the public level I was interested in those things at earlier stage. We know in advanced aging that the health start to decline, etc. Then people start to go hospital or healthcare. But can you give us an example of practical things that been done at earlier stage of life for the schools, university, etc.? Any practical things done toward promoting the public health in schools, university, etc.?
Okay, thank you for your important question. I think so. The public health authority is not fully an executive entity, which means that we have to work with our stakeholders, such as the Ministry of Education, Ministry of Sports, to design, implement, and evaluate the interventions that we are focusing on. So one of the department or section that we have at the Public Health Authority is the health school. So this department is focused on initiatives that's aiming to promote healthy lifestyles at the early age of the school age, as I mentioned before. So each year we have this Rosanama or this agenda for schools to promote their health, and also regarding the health settings programs, we are not just focusing on giving them accreditations to recognition their efforts, but rather than we design a full package of interventions. First of all, we do the guidelines. We have to guide the target groups that we are focused on, and train the target groups at schools. And then we do the awareness campaign, designing the content for the awareness. We have high impacted content for the topics that we focus on. Lastly, we do the accreditations to schools. So I think it's we have full package of interventions. We are not just focusing on one interventions, because this is our program framework. We are doing multi interventions at the same time. We do the guidelines at the same time. We train from that guidelines and also doing the awareness campaigns.
Thank you, Mr. Tariq. Ms. Sana, I have one question. What's the impact of the available vaccine on STIs?
Okay, the impact of vaccine against sexual transmitted infection is not just very important. Now, mandatory in several aspects. For example, in school for human papilloma virus for all girls. Also, when pre-marriage, if some of partner have infection with HPV, they mandatory to get the vaccine. So it is a big rule to avoid the infection. Yeah.
Thank you. Thank you.
Thank you. Thank you.
I think now we will move to honoring you. Thank you so much for this great session.
Now we would like to invite all our esteemed speakers and session moderator to kindly stay on stage so we can recognize and honor their outstanding contributions. Enjoy your break time and we'll be back after 15 minutes. Through the QR code, you could join the 80-second walking stations, take part and pick one of dialogue session, meet Mr. Aja, our interactive AI avatar, and explore many other activities that bringing lifestyle medicine to life. Excuse me, we'll start our session shortly.
Hi again, Abdullah. Take this neat fact that most people knows, but not everyone do it. Staying active isn't just for the young. It's for anyone who wants to keep feeling young.
I agree. A little movement and a little brain work can add years and energy to your life.
So, what activity makes you all feel alive at any age?
Let's dig deeper with our next session moderator, Dr. Naim al-Shammari, consultant in rheumatology and internal medicine, Saudi board certified with fellowship training at King Faisal Specialist Hospital and Research Center. Please welcome.
Assalamu alaikum. Good morning. Thank you for the introduction. We'll now move for the third session, which is about physical and mental activity across the lifespan. Before we start, I'm highlighting the, for any question, please scan the barcode, which is aside the screen. We'll start now with Dr. Melissa Sanderman. Dr. Melissa, she's a double board certified physician in internal medicine and lifestyle medicine with over 25 years of clinical experience, known as a doctor outdoor. She's national recognized leader in nature as a medicine and currently serves as a medical director of lifestyle medicine at Cornwall Health. She will talk about optimizing brain health for longevity, a lifestyle medicine approach to the health aging. With no further delay, Dr. Sanderman, the stage for you.
Do I need to do anything to bring this up? presentation. Can someone help me bring my presentation up? Not quite sure how that. Someone from the conference? Hello. I need my brain health PowerPoint brought up, if someone can find my PowerPoint. Okay, thank you, Dr. Sunil. Well, I will say thank you so much for having all of us here. I come from the American College of Lifestyle Medicine. I'm from the United States, specifically Ann Arbor, Michigan, and I had the privilege of speaking here last May and just had a wonderful experience and so overwhelmed with the hospitality and all of the movement in lifestyle medicine globally. As my introduction said, I am the chair of the Lifestyle Medicine Initiative for the Global Wellness Institute, and actually Dr. Sunil Kumar is part of our committee. So we're working globally to really elevate lifestyle medicine and keep doing what we're all doing. And what's really apparent is that we all are facing the same issues of chronic disease, and knowing that 80 to 90% of chronic diseases are actually lifestyle driven. So my background is internal medicine, spanning close to 30 years of clinical practice, and became board certified in lifestyle medicine in 2019, and currently serve as the medical director of lifestyle medicine for Corewell Health. And it looks like I am ready to go. So we'll be talking about, thank you, Sunil, about optimizing brain health, utilizing the pillars of lifestyle medicine. Okay. There we go. All right, my objectives here. I'm just going to be talking about lifestyle medicine and going through the pillars. And we all are now into day 2 of this conference, so we know and are familiar with the 6 pillars of lifestyle medicine. And I always like to share this cartoon. This is actually from Dr. Dean Ornish, who's one of our pioneers and luminaries of lifestyle medicine. And as you can see, there's a couple of physicians trying to mop up all this water. And just as they get all the water collected, the water keeps coming out. And so what they fail to realize is if they actually fix the leaky sink, all of the problems would be solved. So that's where lifestyle medicine really gets to the root cause of disease, by acknowledging our lifestyle behaviors. So the question is, can lifestyle optimization actually improve our brain health? And hopefully we'll see this, that yes, we can optimize our brain health with lifestyle. And we'll be focusing on dementia. There's many different types of dementia, but really for this point of this talk, we'll be focusing on Alzheimer's dementia. And in the scope of dementia, looking at both in the United States and globally, we're seeing a rise. It's almost like an epidemic of dementia. And in the US, about 1 in 9 adults over the ages of 65 and 1 in 3 adults over the ages of 85 will have a diagnosis of dementia throughout their lifetime. And unfortunately, 2/3 are women. And you can see this graph. When we look at deaths related to disease, we can see that the Alzheimer's deaths are increasing, whereas other disease states, heart attacks, strokes, or HIV are actually decreasing. But we're seeing this growing epidemic. And so by 2050, the number of people in the US that will be diagnosed and living with Alzheimer's dementia is going to be up to 13.8 million. And this very much is a global problem. And you can see these statistics that globally, and perhaps in Saudi Arabia too, we're seeing this growing epidemic of dementia. And I absolutely love this diagram here. This is from the Lancet. And it really shows that throughout the course of our life, it's never too early or never too late to be making lifestyle changes in order to optimize brain health. And so starting from a very early age of low education level, up through alcohol misuse and concussions and sedentary behavior, poor dietary patterns, social isolation, sensory impairment like hearing loss, these all need to be addressed throughout the trajectory of life in order to optimize brain health. So we're going to go through the pillars of lifestyle medicine and focus on ways that we can help our patients maintain their brain health and avoid dementia through the pillars of lifestyle medicine. So focusing number 1 on nutrition. So the standard American diet, in the US we have to say it's very sad, and really the bulk of caloric intake is coming from highly processed foods. In lifestyle medicine, we do promote plant-forward, whole food, plant-based, and we can see that the standard American diet, only about 12.5% of dietary intake is coming from these plants, these fruits, vegetables, beans, whole grains, nuts, and seeds. And so we really want to optimize that. When we're looking at brain health, on the left side of my screen is going to be what's good for brain. Now, I cut out that bottle of wine. There is absolutely no reason that alcohol, you can get resveratrol from grapes. We need to avoid alcohol, but really getting foods that are in the whole food plant category with lots of phytonutrients, lots of antioxidants. On the right side of the screen are going to be things that are not good for our brain. So a dietary pattern high in processed foods, processed meats, simple carbohydrates, a westernized diet, lots of fast food. One of the best things for your brain are going to be omega-3s. And here are some different types of foods where you can get those omega-3s, which are really good for your brain. So we have fish sources. We have, that says canola oil. I actually prefer extra virgin olive oil, flaxseed, chia seeds, beans, dark leafy greens. If you are plant forward, vegan, you don't have to have fish to get your healthy omega-3s. So you can see that there's lots of different varieties to get those omega-3s, which are very good for the brain. In terms of research that's been done, there's the MIND diet, which was actually out of the University of Chicago, Dr. Martha Claire Morris. And the MIND diet stands for the Mediterranean DASH diet intervention for neurodegenerative decline. And what they found was a plant-forward dietary pattern actually could really help prevent dementia. And they categorize, you can see the difference between the Mediterranean diet, the DASH diet, and the MIND diet. There's a lot of overlap. These are very plant-forward dietary patterns. On the right is the MIND diet, where this research has been done. And again, I don't believe that any alcohol should be involved in any of these dietary patterns. And really, we want to cut back on cheese and butter and fast foods, red meats, and sweets. And what they found in the study is that individuals who adhered to the MIND diet could have a 53% decrease in dementia. And even moderate adherence could reduce the risk by up to 35%. And people who did follow the MIND diet had cognitive functioning 7.5 years younger. And this was Dr. Dean Ornish's recent trial that came out, which really looked at lifestyle interventions, including whole food, plant-based dietary pattern, regular physical activity, mindfulness, and social connection, and really had very promising results showing improvements in several cognitive assessments, and actually improvement in the gut microbiome, and an increased amyloid beta 42/40 ratio. So moving on to exercise. And as you can see, our physical activity has definitely decreased with the advancement of technology, and in many cases, that's not a good thing. The American College of Lifestyle Medicine aligns with the American College of Sports Medicine and the CDC with our recommendations for physical activity and strength training. And really the role of exercise, these are all the benefits. And the one that I like to highlight and educate is every time we move our body, we are generating brain-derived neurotrophic factor. And that's basically like miracle grow for our brain that increases synapses, really is just helps our brain to flourish. And some studies looking at physical activity, movement, and decrease in dementia. And walking is one of the best things that we can do. And this is from the UK Biobank study looking at the endpoint of dementia. And what they found were individuals who got at least 9,800 steps per day could lower their risk potentially of developing dementia by up to 50%. And if they had 3,800 steps, it could actually decrease the risk of dementia by up to 25%. So anything is better than nothing. And walking is a wonderful, accessible form of movement. And resistance training is also very important. And this is a study that looked at a 6-month intervention where individuals who had some mild cognitive impairment did some strength training 2 to 3 times per week. And as you can see, that about 47% of participants actually had an improvement in their cognition. Moving on to sleep. So sleep truly is our superpower, and so many things happen when we're sleeping. And one of the ones that I like to highlight is this waste clearance, the glymphatic system. And the glymphatic system is really like a series of dump trucks that all of the tangled protein, amyloid, and tau that collects throughout the course of the day. When we get restorative sleep going through our deep sleep cycles, our REM sleep, we are actually activating that glymphatic system to get rid of those tangled proteins. And here's actually some images of the glymphatic system. And so looking at studies related to dementia and sleep, this is the Whitehall 2 study. And what they found were individuals who were getting 6 hours or less per sleep in their midlife, 50s, 60s, 70s, actually had about a 30% increased risk of dementia just from that poor sleep. Also, screening our patients for sleep apnea. We know that cardiovascular, this is not good for us, and we know it's not good for the partner who's trying to share a bed with them, and also it can increase the risk of dementia. So if you have any individuals or your patients that are at risk of sleep apnea, please, please, please get them tested and treated because their brain health could depend upon that. And risky substances. Again, I'm gonna say there's absolutely no benefit to consuming any form of alcohol for any health, including our brain health. So abstinence is best. Stress management. And we all have stress in our life. There's no medication to take that away. So what can we do? And this is a study looking at midlife stress and does that affect brain health? And when we're talking about midlife stress, this would be major life happenings. So maybe you're caring for a family member who's ill. Maybe you're raising children that you're very at loose ends with raising your kids, or you're going through marital issues, or you have a very, very toxic, stressful job. And so could that affect your brain health? And the answer, it can. So looking at a study of midlife stressors, these long stressors, going through 1, 2, 3 stressors, you can see that the hazards risk ratio does increase for having dementia down the road. Now, we can't avoid those. These are our life. We can't just walk out on our family. We can't just maybe quit a job if we need that income. So what can we do about that? And of course, mindfulness is really a tool that we should all have and teach our patients. I know Dr. Michelle Thompson loves to breathe with her patients in the room. I'd like to do the same thing. So letting our patients know that to take 10 deep breaths, or to practice mindfulness, or to go for a meditative walk, or to journal. These are ways that we can best manage our stress and hopefully protect our brain. Social connection. Dr. Vivek Murthy was the previous Surgeon General of the United States, and he came out about 1.5 years ago with the Surgeon General's advisory on social isolation and loneliness. And actually, it could be the health equivalent of smoking 15 cigarettes per day. So social isolation, lonely, doesn't mean that you don't ever have alone time. It means that you want to be connected with community, connected with colleagues, connected with friends and family. And looking at people as we age, we're finding that individuals, as they get into their 60s, 70s, 80s, and they're socially engaged, we actually see a change in their gray matter. And another study looking at social isolation and loneliness with a 26% increase in the risk of degenerative disease. And my 7th pillar, I spoke last year here about nature. So daily exposure to nature and fresh air, I'm known as Dr. Outdoors. And so Hippocrates was also a Dr. Outdoors. And some studies that are looking at neurodegenerative disease hospitalizations related to exposure to green spaces and blue spaces. So greens meaning trees and tree canopy, blue spaces meaning wadis and bodies of water. So finding that there is a correlation between getting outdoors and perhaps a decrease in risk of hospitalization related to Alzheimer's, dementia, and Parkinson's disease. And also a study showing taking walks in nature actually affect our amygdala. So it allows us to get into this parasympathetic state. So I like to encourage people to try to get some fresh air every day. So in general, key takeaways, just know for our patients, there is something that we can do for brain health. We don't have to rely on medications. And that starts 1% better every day, never too early, never too late. Focus on whole food, plant-based dietary patterns, trying to get physical activity, trying to do some strength training, trying to prioritize enough sleep, practicing stress management, mindfulness, engaging socially, and getting outdoors. So with that, I'll say thank you. And again, gratitude for this opportunity to share my passion with all of you.
Thank you, Dr. Sunderman, for informative talk. The second speaker will be Dr. Mohammed Al-Harbi. Dr. Mohammed Al-Harbi, consultant pediatric endocrine. He's a clinical assistant professor in pediatric endocrine in Dar al-Ulum University in Riyadh. He will talk about effective lifestyle changes and the preventive of chronic disease and improvement of biochemical indicator. Dr. Al-Harbi, the stage for you.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. Let me start first with thanking the organizing committee for inviting me and have this opportunity to share with you this marvelous conference. And thank you for the chairman for the introduction. Actually, I think my lecture, at the end of this lecture, we will have some connection with the previous lecture, actually about the brain development or the brain improvement in the lifestyle. When we are talking about some biochemical and micronutrients, maybe this is the reason why the brain is improving. So first of all, let me introduce the chair, which is the chair of biomarkers of chronic diseases in King Saud University in Riyadh, which concern about the chronic diseases and the biochemical changes with those people. And actually, all the studies they conducted between 2014 until now, until 2025, more than 15 studies, community-based studies on how the lifestyle change the chronic disease prevalence, the biochemical nutrients, and so on. So all the studies I will mention, actually I cannot mention all the 15, I just chose those are very important and related to our lecture. So all of them, they have been conducted in a multi-center basis. It's not only one center. So let's start with the first one, which is effects of different dietary and lifestyle modification therapies on metabolic syndrome in pre-diabetes Arab patients, a 12-month longitudinal study. So this study, the design, there is 3 arms actually of those people who included in this study. One, we call them general advice, who just received general advice about, and I'll mention that in the next slide. The other people who received intensive lifestyle modification program, and the third group who received the general advice with metformin. So the general advice, we just told the people that if you decrease your weight by 5% and you do this exercise, you do that just like that. This is the general advice. The second group, no, we have the program of intensive lifestyle changes, like intensive lifestyle modification program with rigorous lifestyle modification support, which include individual consultation with the dietitian, reduce the total fat intake to less than 30% of energy, consume and increase the fiber intake to 15 grams per 1,000 kilocalorie, and guidelines for physical activity. At least he will start with 5,000 steps, then he can increase it as tolerated. And vitamin D education, that the sun exposure, it's not medication, it's sun exposure at the right time. So this is the lifestyle, and there is follow-up also for those patients who's in this group. The other group, they just received, all the groups received the general advice, but the third group also received metformin 500 milligram once a day. So so we included in this study about, just a minute, I think, yeah, 98 in group 1 and 98 also in group 2 and 98 in group 3, equal male and female. As we said there, the groups that I just mentioned. So after 6 months, there was 3 missed in the first group due to lack of loss of follow-up. In the second group, there is 10 patients have been lost, either because of poor compliance or loss of follow-up, and the last group, about 18, have been lost also because of change of medication, loss of follow-up. Either they just developed diabetes, so we removed them, the medication changed, and we removed them from the study. So after 1 year, there is another 1 in the first group, and another 13 in the second group also lost, and also 12 in the third group being lost. So the rest of the patients who've been analyzed, 94 in the first group, 75 in the second group, and 68 in the third group. And the data analysis being done for 58 because of 9 excluded for missing data in the first group, and 73 in the second group because of also missing data in group 2, and also 9 in group 3. So what is the result? As you see here, this is the baseline. There is no difference between all the groups, but let's concentrate here on the waist. If you go back to the weight and body mass index, there was no change even after the intervention. But here the waist, which is the most important one in obesity to cause chronic diseases like diabetes type 2, there was a significant change after 6 months by reduced by 1.6, and after 1 year by 0.96. And also the blood pressure, the systolic blood pressure also was decreased after 6 months and after 1 year. Regarding the other things, diastolic also there is a decrease, and vitamin D3 there was increased. This just by lifestyle modification without any other medication or interventions. About fasting glucose, also there was a good result increase, but if you see here in the intensive group and metformin group, if you can appreciate the numbers, it may be in favor of general, with metformin group. But still, from the baseline, the p-value is significant. And these 2 stars, that mean the p-value is significant between the baseline and after intervention. This also for the hemoglobin A1C. As you see, in the general, only 0.6 the difference, while it is 0.3 after 1 year and 0.5 in the group of metformin. About the lipid profile, not much. Cholesterol, maybe not also much, but for the first group, there is no improvement, but in the second and third group, still the metformin group is a little bit better. The other thing, like metabolic syndrome in general. If you look to the metabolic syndrome in general, there is 2 things that metformin is better. But if you look to the whole 5 components of metabolic syndrome, the lifestyle, the intensive lifestyle is better in improving as you see here, minus 26, so the p-value is significant, while it is only minus 0.2 in metformin group. So if you are looking just to a particular, which you mentioned, that cholesterol and lipids, yes, maybe in the metformin is better, but if you look to the whole components of metabolic syndrome, the 5 components of metabolic syndrome, still the intensive lifestyle is better than general advice and metformin. And as you see, as you appreciate it here, is that the p-value is so significant in the middle group, which is intensive lifestyle modification. And also for the markers, it's also in the second group, which is intensive lifestyle modification. So the conclusion that the intensive lifestyle modification or low-dose metformin for a period of 12 months significantly reduces metabolic syndrome manifestations in individuals with prediabetes. Lifestyle modifications being superior to metformin, GA and MET, limited weight loss and reduction of hyperglycemia. The intensive group improved all the components of metabolic syndrome together more than the group of metformin. The second study is concerned about also 12 months and hybrid, in-person and virtual, and actually this was during the corona. In the second period of study, it was during the corona, so we gave both virtual and in-person modification. So 3,000 actually entered this study, but 2,600 school students, Saudi children and adolescents aged from 12 to 18 who entered this study. 58 of them are girls. 60 are randomly selected preparatory and high schools in Riyadh City. The study included healthy children and adolescents, whether they were overweight, obese, or normal. So these are three groups: normal, overweight, and obese. The type 1 diabetes, or any child on insulin have been excluded from the study, and written informed consent taken. So the intervention was all the intervention, educational studies happened in the schools. So we sent the team, who was trained team, sent them to the school to give this intervention and draw blood at the start of the study and 1 year after the study. So 3,000 was included, but at the end of the study, we came to 2,600. And because of COVID, 1,886, they did not withdraw blood as follow-up. So the only 643 withdraw blood. So we have all the data about them. We divided into the three groups. I said normal, about 584. Pre-diabetes, about 39, and diabetes, about 20. So just to mention, those they don't know that they have pre-diabetes or diabetes, but we discovered that after from the investigations we have done. And what's going on? What happened? As you see, that the p-value is significant almost in all the components between the normal and the people with either pre-diabetes or diabetes. And then we start the intervention. As I said, we give the education in the school, but after COVID, we start to give the education through online because of the curfew. I will just mention the last two things, which is glucose. Maybe you will not appreciate much improvement in glucose in all the three groups, but hemoglobin A1C, there was a good improvement, and especially with those with diabetes, the improvement from 7.4, which is considered not only diagnosis of diabetes, also poor control of diabetes, and how they changed to 5.9, which is good control of diabetes, or even we can say it's a type of remission of type 2 diabetes, which happened only due to lifestyle management. So in conclusion, this 12-month lifestyle intervention study demonstrates that improving glycemic status is achievable through lifestyle modification delivered through different platforms among Arab adolescents. That mean either in person or online due to that time due to COVID pandemic. The revision of normal, or the reversion of the normal status, was in agreement with the reversion of body mass index. So if you can modify or decrease the body mass index, you can improve this thing. This study actually talking about the lifestyle and spexin. Spexin is a novel peptide thought to have a role in various metabolic regulations. Given its presumed body weight regulatory functions, we aimed to determine whether lifestyle intervention program on weight loss and fasting glucose improvement among people with impaired glucose regulation also alter level of circulating spexin. And what we found, it's actually huge to mention all these things. But what if you just go back, you see that between actually it's 2 minutes. Okay, so there is great improvement. But what I want to highlight that in women the improvement in spexin is better than men, and that was also concomitant with the improvement of other prediabetes and diabetes. So in conclusion, increased spexin level among adults with prediabetes are observed following favorable glycemic changes. The study also suggested that spexin levels correlate inversely with fasting glucose and HOMA-IR. There's another study also about the NLRP3, and I will go fast just to go to the conclusion that the NLRP, there is good improvement after improving in hemoglobin A1C, in fasting blood glucose, and so on. So NLRP3 is the inflammatory markers. So if you decrease that by lifestyle only, and that's what we approved here, then the prediabetes and diabetes also changed. Here we are talking about other micronutrients. I think in this study, yeah. So in summary, the study showed that the beneficial effects of 6 months lifestyle modification program in improving the micronutrients, as maybe this is what I want to say to the previous lecture, that some nutrients like vitamin C, vitamin E, vitamin B6, riboflavin, thiamine, vitamin A, phosphorus, magnesium, iron, copper, all these being changed with the lifestyle in good improvement, and the p-value almost all is there after 6 months is significant. Maybe only for B12, which is not that much, but maybe this is contributed to the health in general and the brain health in particular. The last one is efficacy of lifestyle intervention program using social media as an alternate platform. And I will go to the conclusion directly, which is diabetes prevention programs, whether delivered through groups directly or through the social media, it also has good impact. The last one, which is attendance-based adherence outcome of obesity management program in Arab adolescents, show good improvement, and the conclusion at the end is that greater participants and adherence to the intervention improved target outcomes, particularly in reducing pediatric hypertension among Arab obese adolescents. Our results add to the current literature and have clinical value given the ethnic and cultural variations in compliance with such an obesity management intervention program. The use of virtual platform, the implementation of lifestyle modification among Saudi children still has a lot of room for improvement. Thank you.
Thank you, Dr. Harbi, for your informative talk. The second speaker will be Dr. Andrew Mock. Dr. Andrew is a board certified in family, preventive, and lifestyle medicine. He serves as a medical director. He will talk about the physical activity, prescription, a global key to longevity and vitality.
Hello, everyone. So, hi from Loma Linda, California, from America's Blue Zone. So I'm a medical director for our Precision Lifestyle Medicine program, which is a lifestyle medicine approach to primary care Nationally, I serve the American College of Lifestyle Medicine through advocacy work, also representing multiple fitness associations, including the Medical Fitness Association and our nation's largest advocacy group for exercise, which is the Physical Activity Alliance. In all of my spare time, I'm also a professional 105 kilogram strongman. I've won California's Strongest Man 4 times, competed at World's Strongest Man twice, and I also own my own small powerlifting and strongman gym. So whether it's my own exercise, seeing my patients in the clinic, or the national advocacy and education work, my mission is to close this gap from what we know about the benefits of physical activity to how are we actually doing it in medicine. And so put your seatbelts on. So this is going to be a quick 12-minute sprint through physical activity assessment, prescription, and referral from someone that likes to talk about exercise way too much. So let's put some definitions around our conversation. Physical activity is any body movement that requires skeletal muscle and uses extra energy. So if anyone in the audience is tapping their foot or walking around, anything that they're doing above baseline, that is physical activity, which is a little bit different than exercise, which is structured, planned physical activity done for a specific goal. And 2 main categories about that exercise that we're going to talk about is what I like to call the conditioning or the cardiovascular activity, and the resistance training or strength training activities. So what does the WHO recommend that adults do? So first, we should get at least 150 minutes of moderate intensity conditioning type activity, or 75 minutes if it's vigorous, or a combination of the 2 to reach the equivalent minutes. And then because it provides additional benefit, we should also be doing muscle strengthening at least 2 days per week for all major muscle groups at moderate or greater intensity. And that's a very packed sentence, and we're going to break that sentence down in just a little bit. And as we get older, it's also recommended that we do the combinations of these activities together in what we call multi-component exercise. So that can be doing things like Tai Chi, yoga, even power training with strength training, or doing some of your strength and conditioning at the same time. But it can even do the lifestyle activities like dancing or going hiking with your loved ones. We have robust data across all chronic health conditions that physical activity provides benefits. I really like the saying that there's actually no single lifestyle medicine intervention that provides the second-to-second return on investment compared to physical activity. Because if you only ate right or slept right for 150 minutes out of the week, it's not going to be a very good week for very long. But if you're doing that 150 minutes of moderate intensity activity, you're actually getting most of the benefit. But the truth is, we start to see that benefit very quickly when we're talking about things like mental health and cognitive function. So even the activity that we will do in just a short moment will immediately improve our ability to listen to the presentations coming after this. But there's one silent epidemic that I do want to highlight, and that is sarcopenia, or this loss of muscle mass and function. And classically, we thought that this had to be part of the normal aging process. But the reality is, while there is some aging component, it really is the cultural shift that leads to us engaging in less physical activity. And that power actually decays faster than the strength, which decays faster than the muscle. So our ability to produce force quickly, like what's needed to stop us from falling, is actually decaying faster if we don't do something about it. So the SARC-F is a global questionnaire that can be used to screen for sarcopenia. And then when you identify cases of sarcopenia, very important to treat. And the treatments are very simple in concept, not always easy to accomplish, but it's going to be that appropriately dosed resistance training and then that adequate dietary protein to promote that muscle protein synthesis. So this is the model that we put together to help you think about how to assess, prescribe, and refer for physical activity in the clinical setting. Very important on the screening side of things is you must know what someone is currently doing. So you have to ask them questions about their current physical activity. For individuals with certain conditions like cardiac disease, metabolic disease, and renal disease, we'll want to ask them some additional questions or maybe even do some additional workup to make sure that it is safe for them to do a more intense program. But very important is assessing where someone is mentally. What are the benefits of exercise that they understand? How ready are they for change? And I know we'll have a lot of conversations throughout the conference to discuss behavior change. And then we provide some brief intervention. And that intervention is based on, are they meeting the guidelines or not? Or is there additional benefit that they could be gaining by doing additional physical activity? And sometimes we'll need to kind of tease out, does this person need referral to a supervised exercise program or someone like a physical therapist or a physiotherapist if they need a little bit more guidance because of health conditions, low self-efficacy, low ability to accomplish the exercise, whatever it is. But most importantly, right, is keep the conversation going, because if you talk to your patients about physical activity, they are more likely to engage in physical activity and they're more likely to bring it up next time. So these are the 3 physical activity vital sign questions. So these are quick screening questions that you can do as part of your visits to see, get a general idea if someone is meeting the WHO physical activity guidelines for both conditioning as well as strengthening exercise. And if you have time and resources and the qualified exercise professionals to help you do this, here is what the fitness assessments could look like across cardiorespiratory fitness, muscular fitness, flexibility, as well as neuromotor and balance. So we can test things like VO2 max, or we can do a subjective talk sing test, which I'll show you in just a moment. We can do things like strength testing or power assessments, and we can take formal measurements of joints. But we can also do functional assessments where we watch people move through normal cardinal movements, like standing up from a chair, to get an idea of how well they're doing in their activities of daily living. So I'm preventive medicine. I do not like to order a test that doesn't change the management for my patients. So for me to order something like a VO2 max test where that number doesn't help my patient know what they need to do is very tough for me. So we explicitly designed our exercise testing so that it identified a place for the person to start their exercise program. It taught them critical concepts that they needed to understand to know if it's hard enough. And then because in the US, they're having to pay for these services, it gave an opportunity for them to work with a coach to get some additional guidance if they weren't sure about the movements. And so here's our submaximal talk test. If you're familiar with the Bruce protocol, like what we do for cardiac stress testing, this is very similar, except rather than being hooked up to an EKG every time period where we're increasing the intensity, we're having them say something out loud and seeing if they can talk in those full sentences without having to take a breath every couple of words. And that helps teach them how hard they need to be working, where I'm working hard enough where I can talk but not sing, which is moderate intensity. And very importantly, we're identifying that intensity, but we're also finding out through that graded exercise exposure about how long they're able to work currently. So we're giving them a prescription immediately based off their current performance and given some guidance for progression, so how they can change things over time. But remember that not everybody starts in the same place. So this example here on the bottom is for one of my patients that I was seeing for obesity. She came to my clinic with a BMI of 70. Happy to report with physical activity and nutrition changes alone, her BMI is now down to 62 last time I saw her, but this is where she started. It was hard for her to walk to her mailbox and back. So that's what she could do. And then we gave her how long she would rest between those walks. And each week we would try to add an additional walk. So it wasn't anywhere close to that 150 minutes. But the most important exercise that you will do in any day is the first little bit. And so we made sure that she was getting that first little bit. The truth is the resistance training prescription is a lot harder to talk about all those details in that very packed one sentence, but it needs to be harder than what the body's currently accustomed to doing. And you can do that however you want. Body weight exercises, bands, machines, or my personal favorite is free weights, but it needs to be hard enough internally to drive those physiologic adaptations. And when we're talking about the strength training range, we're going to be doing fewer reps per set. So somewhere between 4 to 12 reps per sets. And we'll talk about how to know if those are hard enough. And when we say 2 or more days per week, that is a description of frequency, but really frequency is a tool to distribute the amount of exercise that you're doing throughout the week. So when we're saying work all major muscle groups at least twice per week, what we really mean there is we want you to be hitting at least 1 set of exercises per muscle group twice per week. But if you're looking for that sweet spot, it's really going to be around 6 to 10 sets per muscle group per week. And they have to be hard enough in order for them to count. And so when we think about what are all the major muscle groups, it's a pretty long list. So if you did a single isolation exercise for every single one of these, that would be a whole lot to remember. So that's why we like to break it up into compound movements, focusing on the ways that you do things in life. And so now we're at the active part of this, and I will go back and watch the live stream, but I can't tell if you're doing it along with me. I'm just going to pretend that you are all the way across the world. So go ahead and stand up from your chairs, and I want your arms to be right here by your shoulders, and you are going to push those arms overhead using those shoulders and triceps to do that vertical push. Picture there's a bar up there that you're going to pull back down towards you using those back and bicep muscles to do that vertical pull. Push your arms out in front of you, doing a horizontal push. And again, there's another bar back there, so you're going to row it back towards you, doing that horizontal pull. You can bend down like when you're touching your shoes, doing that hip hinge. And then we're going to do 10 in a row of these last ones while I continue talking, the squat. So we're just going to stand up and down from our chair 10 times in a row. And so the minimum goal would be that we're doing some sort of upper body push, some sort of upper body pull, and some sort of lower body movement like that hip hinge or squat. And like a true exercise professional, I have no idea what rep I'm on, so I'm just going to keep going while I click through some slides here. So this is the exact resistance training test that we have our patients do. We take them through those 6 compound movements in the way that they want to do it, bands, body weights, machines, free weights, and we help them find a place to start. The trainer can give them small cues in order to know what to actually do, and can also teach them that concept of, is it hard enough? Because hard enough in this case is going to be, did it slow down? So if we were doing those squats up and down from a chair and it never slowed down, it was not hard enough. But if those last couple reps, it starts to look like a little bit of a strain and you see that slow down, that means that it's hard enough. And that immediately translates again into something that's actionable for the patient. So we pick the moves that they could do, we guide them on that effort, saying, hey, we only want a couple of reps left in the tank. Make sure you can tell that it's slowed down towards the end of the set. And then we add additional work as we're going through. And then because variation in exercise creates a larger breadth of adaptations, we'll change things up a little bit. So we might do sets of 6 one week, sets of 10 another week, but always looking for that internal intensity to say, was it hard enough?
2 minutes, Dr. Andrew.
Oh, thank you. And how would you know if somebody needs some additional help or guidance? And it's really just going to be that individual conversation, because it can be factors like clinical risk. Do they need the additional support? Are there different behavioral factors, which could even be confidence? In the US, it's very cost dependent. So I know that there's a sports ministry in Saudi Arabia that oversees personal training, but you would want to make sure that you have a trusted, qualified exercise professional. And one of the most accessible ways that we can do that currently is with virtual medical fitness services. And know your team. know who you should be sending a patient to based off their individual factors. And probably the most important thing to take away from this presentation is that hopefully this conference gives you something in your toolbox to take better care of your own health. Because when we as the clinical team are taking better care of our health, we will take better care of our patients' health. So this is a beautiful hill, Loma Linda in California. I'm very sad that I couldn't see the Aja Mountains there with you this time, but shukran for having me. And I look forward to seeing you next year in person.
Thank you, Dr. Andrew, for an informative talk. The last speaker today for the third session, Dr. Iman Karim Al-Rashid. She's a rheumatology and internal medicine consultant at the Secondary University Hospital. She will talk beyond medication in integrating lifestyle and physical activity and rheumatology practice. Dr. Iman.
Assalamu alaikum. It's a great honor for me to be here for a second time in this prestigious conference. I hope be fruitful lecture, inshallah. First start, this imagine an inflamed joint as a fire city. Actually, our patient describes something like this when they came to the clinic. Our immune system gets its defense, and actually medication act as a firefighter, but actually the joint is still damaged, and they the patient feel their pain. Here's come the lifestyle and try to rebuilding the roads and clearing the air and restoring the rhythm. And this is our mission. This is our medication stops the destruction, and lifestyle try to rebuild the joint again. So lifestyle and physical medicine is influence the activity of rheumatologic disease. It influences the onset and severity and outcome. And that's what we'll discuss in our agenda today is how physical activity and lifestyle influence the rheumatological disease, and also the new guidelines in rheumatological disease, and how to implement lifestyle medicine in our disease management for rheumatologic disease. Let's start with physical activity. Actually, physical exercise influence the clinical effects like the pain, psychosocial function, and aerobic function also. And here it influences the innate immune system, where the leukocytes go toward the CXL8 and actually the inflammatory response of the is influenced by releasing some myokines called interleukin-6, which is active in this time as anti-inflammatory effect with decreasing the TNF and interleukin-1. Also, it downregulates the matrix metalproteinase 1 and 13, and which help in protect the joint from destruction. Long-term physical activity actually also regulates the oxidative stress, which also help to protect the joint from destruction. In this meta-analysis, they discuss the 16 intervention in adults for rheumatoid arthritis, and assessing the effect of physical activity and the sedentary lifestyle or sedentary behavior. And they show in their results that lifestyle, physical activity, and sedentary behavior interventions resulting in statistically significant reduction in disease activity. Also improvement in the observed in the physical activity levels, in functional ability, cardiovascular fitness, and decreased fatigue. So they recommended to increase the physical activity and lower the sedentary behavior, improve select clinical and patient-reported outcome in rheumatoid arthritis. So what about the exercise intensity, or what we describe for the patient, or we're introduced to the patient, is high intensity, moderate intensity, or low intensity? Actually, the Korean data show that people engaging in high intensity exercise had a lower hazards for seropositive rheumatoid arthritis, and even moderate activity lowers the inflammatory markers and fatigue. Movement literally reduces the inflammation and is our built biologic therapy. Let's go to the balanced diet, and as we all know that anti-inflammatory diet like Mediterranean diet, plant-based, high fiber diets, and are linked to reduce joint inflammation, especially in rheumatoid arthritis patient and osteoarthritis patient. Also omega-3 fatty acid containing diet. While negative influence come from diets high in red meat, saturated fats, and sugar, which increase inflammation and arthritis. Also, diet rich probiotic rich foods helps the gut microbiome modulation and act as anti-inflammatory effect. These balanced diet patterns are believed to beneficially modulate the gut microbiome and reduce the systemic level of inflammation, lessen oxidative stress, all of which contributes to improve joint health and reduce progression of inflammatory arthritis. Even independent of weight loss, actually the patient is having weight loss or not, this anti-inflammatory diet intervention demonstrate a measurable reduction in inflammatory markers and symptomatic improvement. And they highlighting the biologic effect of diet on inflammation. So what about good sleep, which is very important actually for our patient? As we all know, poor sleep is consistently associated with higher inflammatory activity. Studies show that people with insufficient or disrupted sleep have increased white blood cells count and higher level of inflammatory markers like CRP, interleukin-6, and tumor necrosis factor alpha. In contrast, people who report good sleep quality tend to have lower circulating inflammatory cells and cytokines. And this has come from sleep loss activates the sympathetic nervous system and HPA axis, and this increases the stress hormones and blood pressure, which stimulates the endothelial and immune cells to produce inflammatory mediators. And over time, this process contributes to higher systemic inflammation. So patient with disrupted sleep, sorry. So patients with disrupted sleep often have higher decrease in activity, more tender and swollen joints. And this shows a two-way relationship. This patient who have worsened inflammation and severe inflammation have a worse sleep, and also poor sleep will amplify the inflammation and symptoms. So improving sleep through better disease control and better pain management and behavior strategies can help to lower the inflammation and improve joint outcomes. Next, we go for the effect of smoking, and actually many studies show that in rheumatoid arthritis, smoking increases the risk of ACPA positive rheumatoid arthritis, and actually it's linked to the total amount and the duration also of cigarette smoking, is those response relationship. So we come for our food, movement, and good sleep is our anti-inflammatory prescription. And that's why the guidelines actually start to include the lifestyle medicine in their recommendation. And this is started by the law recommendation at 2018, where there is the first time they include physical activity in people with inflammatory arthritis and osteoarthritis. And this comes with 4 overarching principles where there is physical activity is safe and beneficial when tailored to the individual. Exercise should follow public health fit guidelines. Also, all health professionals should promote physical activity. Exercise delivery should be individualized, progressive, and evaluated. And this is a recommendation come after over 50 randomized control trials confirmed that aerobic and resistance training improve muscle strength and function and cardiorespiratory fitness with no increase in flares actually. And after that, we come to the 2021 ULAR recommendation regarding lifestyle behavior and work participation to prevent progression of rheumatic and musculoskeletal disease. And here they include more lifestyle domains like exercise, diet, weight, alcohol, smoking, and work. And as a summarize of the recommendation, they stress that lifestyle modification as a complementary or complementary to medical treatment and it's not replacement, and provided guidance for multidisciplinary shared decision-making in lifestyle management of rheumatic and musculoskeletal disease. And also they show diet recommendation highlighted on the benefit of balanced diet, but not a specific diet. And reflected increased focus on patient empowering and holistic health rather than targeting one lifestyle behavior. And lastly, we came to the 2025 updates of ULAR recommendation. And here the ULAR 2025 moves from exercise is safe to lifestyle, it is therapeutic and tractable. And actual recommendations, they didn't change, but they what they added is the practical tips, which is very important actually, with the use of accelerometer or fitness trackers to motivate and monitor progress. And they schedule brief check-ins to encourage adherence and adjust plans based on feedback, incorporate simple and low-impact activities like walking, cycling, or water aerobics suited to the patient ability. They offer resources for healthy diets, smoking cessation, and stress reduction alongside exercise advice. And that's why in recently
2 minutes.
Recently published a trial, the RA Heal Dial. It is recently published in September 2025. They actually give a whole program for lifestyle modification for patients with RA with newly diagnosed or diagnosed within 12 months. And the result was that DAS28 CRP improved, fatigue and depression improved also. And also what is very important is biologic proof that lifestyle reprogram inflammation by reducing the interleukin 16 in F-alpha and improve HDL function. So it's our true healing and remission plan is about biosocial, biopsychosocial model, which is the medication is important, lifestyle is important, and also psychosocial intervention is important. And this is our mission is to make a solution for the implementation of this program in daily patient management is by hybrid program, digital tools, and team-based care. So our take-home message is we are no longer only prescriber of biologics, and we are partner in motion. And in everyday prescription, we have to do 2 prescription, 1 for medication and 1 for movement and lifestyle medication. Actually, it's important to help our patient to rebuild their own city. Thank you.
Thank you, Dr. Iman. I would like to invite all the speakers to the stage for the question. Thank you for the speaker for the informative talk. Question to Dr. Harbi that there is a question that all are you study in the KSA or not?
Yes, actually, all the studies have conducted in Riyadh city and all local. So nothing outside. Yes.
And the other question that, what's your single advice? You have multiple advice for lifestyle change modification. What you have any single advice for the audience?
Actually, from all the studies we have been conducted, we did not only concentrate on those normal people or with prediabetes, also diabetic patients, whether they have type 1 or type 2 diabetes. So don't depend on the treatment alone as a professional. And I hope that the lifestyle should be like a prescription. You prescribe lifestyle to the patients, whether they are normal with obesity, only risk factors, or other risk factors, or with prediabetes or diabetes type 1 or type 2. You in addition to write the insulin and the oral hypoglycemics, you write also the lifestyle changes, like how much exercise he should do, refer him to a dietitian so he can have a full prescription about his diet and the nutrition. So I hope that there is a prescription called lifestyle prescription where you can write it for the patient and give it to him that should follow that.
Thank you, Doctor. Question, Dr. Sanderman, that are we have head-to-head study for optimizing brain health? Do you have that?
The Dean Ornish study that came out was actually looking at just their control was just people just kind of getting some counseling, some support, just following they're told to eat a healthy diet, just kind of keep doing what they're doing, and did have some social support versus that intervention arm was that whole food plant-based dietary pattern, regular physical activity at least 5 days per week of that 30-minute moderate intensity that Dr. Mock was speaking about, mindfulness practice that would be journaling, breath work, meditation, and then social support. And the social support was group support 3 times per week, 1 hour intervention. And it was not only the patient, but that had some cognitive impairment, but also a partner, a spouse, a family member. And so that's where we did see improvements compared to the control intervention, where they saw improvements in those cognitive assessments. They actually saw alterations in the gut microbiome with more bacterial diversity. And then they saw that increase in that amyloid beta 42/40, which is really a good marker for looking at Alzheimer's dementia. So I think that Dean Ornish trial, and he actually was one of our keynotes at the American College of Lifestyle Medicine annual conference that was just 2 weeks ago in Dallas, Texas. And he shared a lot of this data. So that's more of the trials that we need to show that in terms of all chronic diseases and including brain health, that our interventions are successful and do work.
Thank you, Dr. Sandra. Question for Dr. Iman, that as a rheumatologist, that we are facing rheumatoid arthritis instantly, and they are not in the flare, and usually they are and end up with fibromyalgia. So the fibromyalgia itself can cause pain, and even if you have lifestyle modification, sometimes there is no improvement. What do you comment?
Actually, we are facing this issue in everyday clinic. The patient come with pain and he couldn't move, he couldn't, or she couldn't move. Mostly our patients are females. She couldn't move. She even doesn't have the willing to move. And actually, what we are acting for is how they are convinced that they will change their life with movement or with changing their mind about this physical activity will make them more healthy and they will overcome their pain. And actually, we will start with a small exercises at homes and coming with the walking. Then, okay, after that they feel better, so they come for more exercise or for more training. And actually, we have a patient who are working many hours in physical activity, and they are getting better with no need for more painkillers. But actually it's come from slow and then increasing the amount of exercise.
Thank you, Dr. Iman. Thank you all the speakers. No further question. By this, we conclude our session. Thank you all.
We warmly invite you, our designated speakers and session moderator, to stay on the stage to acknowledge for their valuable contributions.
Abdullah, could you tell me which is more important, living longer or living better?
Well, Abdul Majid, living better means living longer.
Okay, then let's ask our guest a question. Which lifestyle change you would make to live better?
You'll explore that with our next session moderator, Dr. Abdulaziz Al-Gahtani, consultant ambulatory care clinical pharmacist and chairman of the Ambulatory Care PSN, Saudi Society of Clinical Pharmacy. Please welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to take this a moment to thank the organizing committee and scientific committee for this such phenomenal and international conferences that reflect in our one of the fundamental of 2030 vision in longevity and healthy lifestyle. Moving to the fourth session of today, entitled Aging and Longevity Research Lifestyle Strategy for Health Span Extension. In this session, we will explore practical and evidence-based medicine approach that improve long-term health and healthy aging. We have four distinguished speakers. They will highlight on all the aspects in terms of chronic disease, geriatric, and even though from critical care to the aging long life approach. We will start with our first speaker, Dr. Abdurrahman Al-Gabbani, a consultant endocrinologist at King Faisal Specialist Hospital and Research Center, and American Board Certified in Internal Medicine, Endocrinology, and Life Medicine. Please welcome with me Dr. Abdurrahman, and the floor is yours.
Assalamu alaikum wa rahmatullah. It's a great pleasure to be with you all today, and I'd like to take this opportunity to thank the organizers for inviting me. Am I going to be able to see the slides on the screen here, or? Okay. Okay, so to start with, we're gonna, I have to turn a little bit. Okay. So my speech or my talk is not in particular about longevity, but it definitely pitches into that and feeds into longevity. So we're going to talk about diabetes prevention and management, lifestyle strategies to achieve that goal. So the outline is that, it's a bit awkward, sorry about that. So we're going to start talking about 3 points. First one is induction of remission in type 2 diabetes following lifestyle interventions. The second is preventing type 2 diabetes in people with prediabetes using lifestyle interventions. And the third one is preventing type 2 diabetes in healthy individuals using lifestyle changes. Right, to start off with the first point, induction of type 2 remission, type 2 diabetes. Now, we need to start with the definition. So the definition of remission is set as bringing down the hemoglobin A1C to less than 6.5 for at least 3 months without surgery, devices, or active pharmacologic therapy. And that definition aligns with several organizations, including the American Diabetes Association. Now, the American College of Lifestyle Medicine endorses remission or setting remission as the clinical goal for type 2 diabetes. Now, this is through following a whole food plant-based type of dietary pattern or physical activity and the other pillars of lifestyle medicine. Now, why is this important? In general, I get very excited for my patients when they drop their hemoglobin A1C below 7%. And I get even more excited when they drop it further below 6.5. What about deprescription? They're actually few and far between. So one would ask himself or herself, why is that? Why are we not deprescribing medications when we reach good control of diabetes? Well, the answer is simple, because that's not the goal. In general, when we treat patients with diabetes, our goal is to bring them under control, but we rarely set a target of inducing remission. So that is the importance of this key recommendation here. Now, in general, dietary intervention is placed in parallel with pharmacologic therapy to bring patients with type 2 diabetes into control. And there is, of course, no harm in using pharmacotherapy. It's a standard of care. But again, setting the goal for remission should be considered. And I think patients need to know that this goal is achievable if they wish to go through that route. So in the next few slides, I'm going to share with you some data from randomized controlled trials that set diabetes remission as the primary goal for therapy. So in this study, the primary care-led weight management for remission of type 2 diabetes, it's called the DIRECT study. It's an open-label randomized study. It's based in Scotland and Northeast England. They included people between the age of 20 and 65, and those were diagnosed with type 2 diabetes within the past 6 years. The Average body mass index is 27 to 45, and they were not on insulin. The intervention basically was to stop at that point all anti-diabetic medications and all antihypertensive medications. They started those patients on total diet replacement. They put them on a formula diet with 825 kilocalories on average for 3 months. And then that could be extended up to 5 months based on certain conditions. And after that, they started stepped food reintroduction, which took place anywhere from 2 to 8 weeks. And following that, they had structured support for long-term weight loss maintenance. The interesting part here is that the outcome was weight loss of more than 15 kilograms or remission of type 2 diabetes. And you can see here on the top left graph, the group that reached the goal of losing more than 15 kilograms. Their average weight, by the way, was 100 kilos. So 24% of the population studied reached that goal. Top right, you can notice that the intervention group, 46% of them achieved complete remission of type 2 diabetes within 1 year. And you can see that the more body weight they lost, the more likely they reach remission. And you can see the red line here where the drop in the weight, which was a major contributor to type 2 diabetes remission. They extended the study for another year, and you can see the results. Top left, the percentage of people who managed to maintain the 15 kilograms of weight loss decreased, as we see in a lot of these studies. Top right, you can see that the remission rate dropped from 45 to 36%, and the weight across the board is shown here. So another study which is really important is the look-ahead study. It's a randomized control, it's an older study actually. This was in 2003, and there were several publications that came out from this study group. But in essence, it's a randomized control trial to investigate the weight loss effect on prevention of cardiovascular disease in type 2 diabetics. And the inclusion criteria, they included more than 5,000 men and women aged 45 to 74. They were all diagnosed with type 2 diabetes more than 6 months prior to enrollment. Average body mass index more than 25. Average hemoglobin A1C was 11%. And they had a stable cardiovascular risk factor management. So the randomization took place. The intervention group underwent intensive lifestyle interventions, which included weekly group and individual counseling for the first 6 months, 3 sessions per month thereafter, with twice monthly contact during the remainder of the time. They had put them on reduced caloric intake of 1,200 to 1,800 calories. Physical activity was achieved by, or they prescribed more than 175 minutes per week of moderate intensity physical activity, and there was reduction in type 2 medication as needed. The control group received routine care. So on an ancillary analysis, that was not a primary outcome, but the ancillary analysis, it showed that at the first year, patients, the rate of remission in the intervention group was around 11%. You can see the light bar at the first year. Compared to the placebo, it was clinically significant, and the remission rate decreased over the following years in this study. So 11% remission rate from this study. Another aspect of lifestyle medicine, which is coaching, and this is a very interesting randomized controlled trial that was conducted in Denmark. It depended on counseling or coaching. So they took 170 adults with diabetes. The average A1C was 7.4%. And they randomized patients to either receiving e-health app or web-based coaching with behavioral techniques and live monitoring after the initial 1-hour face-to-face motivational interview. And the control group received the usual care, the standard care. So the duration of this study was 6 months. It's a bit short, but the outcome is remarkable because those who underwent the intervention, they lost on average at 6 months 4.2 kilograms of weight compared to 1.5 kilograms in the control arm. And the percentage of patients who went from A1C above 6.5 to below 6.5 in 6 months was around 39% in the intervention group. And both these results are statistically significant. Now, this is a meta-analysis of all the randomized controlled trials that put the primary goal as remission of diabetes by lifestyle changes. It included 18 studies. 8 of those studies had multimodal pharmacological therapies, and 10 of those studies had non-pharmacological interventions. And the total duration of type 2 diabetes was anywhere between 1.2 to 6.4. The average age was 53, and the study duration ranged from 12 weeks to 18 months. So what did they find in this randomized controlled trial? These are the studies enrolled, which is part of the non-pharmacologic intervention. Overall, the odds ratio of achieving remission via multimodal pharmacologic intervention, the relative risk compared to controls was 1.75. But the surprising number was that non-pharmacologic interventions achieving, the relative risk of achieving complete remission was 5.8 compared to control. So remarkable results seen here. Now, there's a position statement or consensus statement issued, published by the American College of Lifestyle Medicine in 2022, and it focused on dietary interventions to treat type 2 diabetes. They collected or they enrolled 49 studies and came up with 69 statements regarding nutritional therapy for type 2 diabetes with the aim of remission, inducing remission. And there were many key statements here. I'm going to list a few of those. High-intensity dietary interventions can achieve remission in many adults. Diets promoting remission also lower cardiovascular disease risk. Reimbursement models should prioritize lifestyle interventions. Whole food, plant-based diets are more effective than standard diet. Minimizing ultra-processed food is essential in this case. Low-fat, plant-based diets can sustain remission. And I'm going to skip the rest for the sake of time. And then, of course, the guidelines came up this year, which is 122 pages, excellent resource for management with lifestyle modification. I'm going to move forward to my next goal, which is to discuss the role of lifestyle modification in pre-diabetics. And I'm going to bring one example, which is the Diabetes Prevention Program, a very famous study. Basically, it included 3,000 individuals with elevated fasting and post-prandial or post-load glucose. So these are high-risk patients to develop diabetes later on. Their average BMI was 34 and mean age was 51. So they randomized these patients into 3 groups. The first group was the placebo group. The second group received metformin twice a day. And the third group underwent lifestyle modification program, which included aiming for 7% of body weight loss via calorie restriction. They engaged in physical activity 150 minutes per week. There was also group counseling, meal replacement, and the average follow-up was 2.8 years. So lifestyle intervention reduced incidence of type 2 diabetes by 58% versus placebo, while metformin only reduced it by 31%. And this is a famous graph. You can see over the years, lifestyle modification was more efficacious than metformin and placebo. There's nothing wrong with using metformin, of course, but again, just to show the power of lifestyle modifications here.
3 minutes.
Yes, thank you. So again, the people who were enrolled into lifestyle dropped their weight, which is a major player in achieving remission for type 2 diabetes. Finally, I'm going to talk about prevention of type 2 diabetes in healthy individuals. What can they do to reduce the risk of acquiring diabetes? And I summarized it here in this table. Those are the 6 pillars of lifestyle medicine and what is related to those in terms of either increasing the risk of type 2 diabetes or decreasing the risk. So starting off with nutrition, high intake of sugar and sweetened beverages increases the risk of diabetes. High intake of red and processed meat also is a major factor here, while the Mediterranean diet or plant-based diet reduces that risk. When it comes to physical activity, sedentary behavior, prolonged sitting also increases the relative risk of acquiring diabetes, while achieving the targets of more than 150 minutes of moderate intensity exercise per week decreases that risk. When it comes to stress management, we know that it also increases the risk, and mindfulness and stress reduction interventions help reduce that. Sleep is essential. We've heard many people talk about sleep today, so it's essential in decreasing the risk of type 2 diabetes. Finally, social connectedness and avoidance of risky substances have also been shown to decrease the risk of acquiring diabetes mellitus. And of course, smoking cessation plays a major role in this case. And with that, I conclude. My conclusion here is the following. So remission is a realistic and evidence-based clinical goal for patients with type 2 diabetes, especially those with duration of less than 6 years, BMI more than 27, and highly motivated individuals to undergo that trial, basically. Sustained weight loss or avoidance of weight regain is the strongest predictor of maintaining remission. Every 1 kilogram regained increases relapse rate by 10 to 15%, and this is from the direct 5-year follow-up. I showed you the 1 year and 2 year follow-up, and this is from the 5-year follow-up study. A multimodal intensive lifestyle intervention, which includes very low calorie diet, significant calorie deficit, physical activity, and the rest of lifestyle changes can help in achieving a sustained remission. Provider training and support and non-judgmental communication is essential. Intensive lifestyle intervention is superior to metformin in preventing progression of pre-diabetes to diabetes. And finally, addressing all 6 pillars of lifestyle medicine is also essential in maintaining this remission. Thank you very much.
Thank you, Dr. Abdurrahman, for raising this new concept of diabetes management. We are beyond of controlling disease to the level of achieving the remission rate. Now moving to the next session with title Aging Wellbeing Design, Integrating Lifestyle Medicine into Age-Friendly Geriatric Care. Dr. Anna Lufau, Executive Director of Trigger, an institution of optimal aging and professor at University of Louisville. Please join me to welcome Dr. Anna.
Good afternoon or good morning. I'm not even sure anymore. So nice to see you all here. I'm very happy to be here. I'm joining you from the University of Louisville in Kentucky. That is the place where you can find Kentucky Fried Chicken. It's the home of Kentucky Fried Chicken. So you can all come there and eat from the first place where it was ever made. So thank you for the opportunity to talk to you today about how can we change the way that we care for older adults. First, I want to congratulate everyone in this community in Hale for reaching the amazing achievement of having a life expectancy of 83 years. This is more than we have in the States on average. So it's an amazing accomplishment. However, with that comes a lot of responsibilities. And this is what I want to talk to you all about today, is what is our responsibility here as people who care for older adults. It's good that we have this wonderful life expectancy, but we now need to make sure that our system can handle it. Okay. There you go. I'm so sorry. I've got some technical difficulties here of managing this thing. To my next speaker, be careful what you do here. It may mess with you. Okay, so what we're going to talk about today is how lifestyle medicine principles can transform general geriatric care into a vibrant place where we really took well care of our older adults. We are going to explore the intersection between the 6 pillars of lifestyle medicine and the 5 M's of age-friendly healthcare systems. And then we're going to give you an example of what we are doing at the Traeger Institute Optimal Aging Clinic, the work that we do there to do this kind of care that we talk about here today. And then finally, we're going to give you just very quick outcomes of that work. So first, let's look at traditional geriatric care versus lifestyle medicine. First of all, we know this, and we've already talked about it, that the primary care of normal, basic, traditional care is to manage diseases. We all know as you get older, you get more diseases. In lifestyle medicine, you want to prevent or reverse these diseases. In geriatric care, your approach is medical, your approach is pharmaceutical, your approach is diagnostic. In lifestyle medicine, it's behavioral, it's holistic, and it's empowering. The orientation in traditional geriatric care is to be reactive, but we want to be proactive. The outcomes is to get stability and basic functioning, where we want vitality and longevity when we talk about lifestyle medicine. The patient role is to feature the direction of the physician in traditional care, but in lifestyle medicine, it's active participation in your own health and your own longevity. So this is an important curve. When we are born, we immediately start to age. And as you can see, as the curve, as the X line progresses towards death, you see what happens to the Y-axis. Our health and our quality of life declines. So the older you get, the worse is your health and the worse is your quality of life. And what we're trying to do by incorporating lifestyle medicine in the care of older adults is to see if we can change that curve into a straight line. Let's square that curve so that at the end of life, we can still have health and we can still have quality of life. This is a very important slide for me that lies very near to my heart. Many people in the world of lifestyle medicine and the world of aging care talk about to successfully age. What does it mean to age successfully? They many times talk about it as avoiding the disease, to engage with life, and to maintain a high cognitive and physical function. The problem I'm having with that part is that what if you do not? Are you not able to avoid disease? What if you get cancer? What if you get dementia? Does it mean that you are no longer successfully aging? And that's where I want to say that I think this is where the change needs to be. We need to start talking about flourishing as we're aging. And what I mean by that is the following, that we can talk about our life going well, that we can talk about optimal life functioning despite the disease that we have. We can struggle with diabetes, we can struggle with dementia, we can struggle with cancer, but we can still live to our fullest in the midst of what we are experiencing. We want to maintain a level of functioning that's possible for us in the moment. We want to optimize our engagement goals with life in general. And then, to me, the most important part that sits at the root of that tree of flourishing is to proactively and reactively respond and interact with the context that's coming our way. I have been diagnosed 4 years ago with cancer. After I had my scare that I'm going to develop dementia because I had the genetic predisposition to get dementia. And what did I get? Cancer. So what do I do with that? Am I now saying that I'm not successfully aging? No, I think I'm flourishing in the midst of my disease. I had 2 bouts with cancer in the last 4 years, and I've beaten it twice. And I'm saying in that sense that if we can learn how to live with our diseases in a positive and effective way by introducing lifestyle medicine into what we do and how we respond to what comes our way, I think we can help the aging population to age well. So what is the intersection between the 6 pillars of lifestyle medicine and the 5 M's of age-friendly health systems framework? This is what I'm going to talk to you now. So we all know already by now what is the 6 pillars in America that we talk about lifestyle medicine. And as you guys here in Hale have decided in 2025, you added four pillars: driving disturbance, smart technology disturbance, spirituality, and sexuality health. That's an interesting addition to what we have in the States. But that's the pillars of lifestyle medicine. Those are the things we're working on and we're talking about at this conference. So why a 5M model of age-friendly health systems to bring the other side of what I'm going to talk about in here? So it's important to know that healthcare of older adults is complex. As I say, as we age, the more diseases can come to us. So it's a complex thing to deal with, is how do you help and support people aging well? So the Institute of Healthcare Improvement and the John I. Hartford Foundation with the American Association of Catholic Health Association came together and they created this Institution of Healthcare Improvement statement that there's 5 things we need to take focus of when we deal and manage the care of the older adult. We have to make that the goal, is to make it age-friendly, and everything we do, every encounter with an older adult has to take in these 5 M's into account. It's evidence-based, it causes no harm, and it aligns with the patient and the family goals. So what are these 5 M's? The first M, this is a very important one, is what matters to me as a person. What matters to me as a 62-year-old individual that lives with a high risk of dementia to develop and a second bout of cancer? What drives me to stay healthy? Those are the things that we need to take into account when we work with our patients. So we need to ask our patients, what's important to you? What's your goals in life? It's not just what the doctor tells you to do, but what do you want for your life? Very important question to ask an older adult before you even start taking care of them. So what matters most? Let's figure out what's their healthy care goals and put it in their chart so that we know what to focus on the next time we see them. The next part is the mind. We had a lot of talk in the earlier session about brain health. And brain health is a very, very important part of aging. And what about brain health? We need to make sure that we take care of the modifiable risk factors for dementia. Then we need to make sure that we increase the mood of our patients. Depression and anxiety is very prevalent in the older adult population. So what do we do to help and support them? Then medications. There's way too many medications that we give to older adults. There's a lot of polypharmacy happening. What do we do to prevent that? And then mobility. How do we get people moving? How do we get older adults moving? They say the more an older adult move, the healthier they will be. So it's all part of what we need to do to get to that 5 M's of age-friendly healthcare. So the shared principle of these approaches is the goal is healthy aging and optimizing behavior. We focus on the patient goals, aptitude for complex and holistic thinking in both of these approaches, and the goal is developing optimally functioning systems and interdisciplinary teams. So this is just to show the alignment, why matters most, align with all the pillars, multi-complexity the same, and it's easy to see where medications, mind, and mobility fits in. So now is the main focus for me in the last 4 minutes to just give you a short example of what we are doing at the Traeger Institute Optimal Aging Clinic. So this is our team. We have a team that consists of geriatricians that they're doing this specialized geriatric care. And these geriatricians told me a few years ago, what's the point of helping an older adult to start exercising? They have changed completely over the last 7 years of we starting to do this work. They totally believe in this approach that we have right now. Then we have our nurse practitioners who do the primary care in our clinic. We have a clinical social workers who do the care navigation. We have the licensed clinical social workers who do the behavioral health. We have a pharmacist who's doing the medication and management. We have community health workers who do the resources and social support, physical therapists for movement, nurse practitioner that focus in nutrition to do all our nutrition classes, and then a nurse and medical assistants to support the nurse practitioners and the geriatricians, and then finally a technician in the lab. So this is just an example of our space that we train. I won't go further in there, but this is our additional wellness services that we also have in our space. We have a yoga instructor that's doing yoga. We have a massage therapist who's doing massage therapy, exercise physiologist, an artist, chef, older adult volunteers who started a social club in our space. We have law school faculty and students who do our law clinic. We have social work faculty and students who come in and do drumming. We have patients and families. You can see there is a patient waiting to be seen who's playing on the piano in our waiting room. We have people who's building puzzles. It's just a really vibrant and energizing community in which we work together as patients and providers to provide care for our older adults.
3 minutes.
Okay, it's just a few pictures to show you. This is our kitchen where we train people, drumming, social club, that is Tai Chi, and that's our art class, and here's our exercise area, and we have a law clinic. So how do we do all this? Just to take you very quickly through what our workflow is in our clinic. It starts with a self-assessment. We have validated this tool. It's a Flourish Care Index. It's a self-assessment of biopsychosocial health. It embeds the 5 M's and the 6 pillars. And we're trying to get a baseline when they come in. Each patient get to complete this and then complete it every 6 months. Then we do an annual wellness visit that we can get every older adult, 65 plus, must have an annual wellness visit on file that comes to our clinic. The clinical social worker and the registered nurse are mainly responsible for doing this visit. And then they all end with a care plan in the medical record and with referrals to all the resources that I showed you earlier that we have in our space. Medication management, we have a pharmacist that's there every week who look at all the medications. We have case planning meetings where we talk about the medications with the whole goal of trying to reduce the amount of medications that we prescribe to our older adults. The workflow, we have primary care and behavioral health together in one space. It's not a referral out. We have it right there. When people experience any behavioral health concern or mood challenge, we see them right there in our space. And then finally, we address the social determinants of health because we totally believe that in this care plan, you cannot have a care plan where you tell people to go and eat healthy, but they are food insecure. Or you go and tell them to go and exercise, but they have no place to go to. So that is part of what we do together. We have social workers, community health workers, all working together with everyone else in that space to create a vibrant, holistic care for our older adults. My final slide is the real-world outcomes. This is the data that we have for 721 patients over 2.5 years. We see that on average, there's a significant improvement in their total scores from beginning to end. We check them out every 6 months. They stay with us in the clinic, and we can see great improvement in biopsychosocial functioning. So we think this is the way to go and the way to care for patients.
2 minutes.
And that's it.
Assalamu alaikum. Good afternoon. Just for announcement, we will delete the break. We will continue our program session after session. Feel free to take some food and drink to catch up because, you know, the schedule is very busy and to catch up with the time. There is no snack and prayer break, but feel free to take your prayer or food and we will continue our sessions. Okay, thank you very much.
Thank you, Dr. Anna, for your interesting presentation and your excellent clinical practice in geriatric patients. Moving to the next session with Dr. Michelle Thompson, with the topic transforming health from within, integrating lifestyle medicine from longevity, health span, well-being, and systemic change. Dr. Michelle, triple board certified physician in integrative lifestyle and osteopathic family medicine, and a fellow of the American College of Life Medicine. Please join me to welcome Dr. Michelle.
Hello, everyone. Thank you so much for having me here. I'm so excited to be with you today. I'm not going to go through all of these objectives that I have listed here, but my slides are available to you. Let's see. You were right, the clicker. How do you get it to go? There we go. It's the green button. Yesterday it was the red button. I don't know. It's just whatever. So really, we're going to talk about all things how to create systemic change so that healthcare can be forever changed, which is what this whole conference is about. So I want to share this photo with you because this is last year when I was here for my very first time in Hael, and I was treated so kindly by so many people, and you all stole my heart and bought me my abaya, and I took it to the United States, Pittsburgh, Pennsylvania, and I brought it back to wear today. So thank you so much for having me back to be with you. A little bit about me. I've been doing this in my own life since 1992 when I became a mom, and we'll talk about why I think that's really important. I really think that we need to be that change that we want to see in the world, and so it really starts with us. I've ran a massage therapy school way back when. That's when I became an integrative physician, went to osteopathic medical school, and then I have been working for the University of Pittsburgh Medical Center for the past 20 years, and in the capacity of a family medicine physician, as well as lifestyle, integrative, mind-body medicine, physician well-being, as well as systemic change in our medical schools, as well as in our residency programs. And we're going to walk through that. I'm also the medical director now at the University of Pittsburgh Medical Center. I'm an associate professor at the University of Pittsburgh School of Medicine. I am also trained physician coach and on the board of directors for the American College of Lifestyle Medicine. So at UPMC, University of Pittsburgh Medical Center, we are national leaders in offering comprehensive lifestyle medicine, not just for one-on-one assessments, but also in group medical visits. I haven't heard much talk of that today, but we're going to go through that and how that really truly can be something that can change healthcare. We've talked about how there's a shortage of physicians, there's a shortage of residency programs, medical student education. And so one way we can increase access to care is to bring people in through group models as well as virtual care. We have been a member of the American College of Lifestyle Medicine's Health Systems Council since the onset, and that actually has been at the very beginning, and now there are over 120 hospitals across the United States that are part of the Health Systems Council. What we do is we help people come together and create change. We share ideas, we create implementation models, just like what we're doing here today. We're coming together and we're sharing ideas so that we can advance healthcare. At Lifestyle Medicine residency curriculum has been implemented into our residency programs in not just family medicine, but also internal medicine, physical medicine and rehab, as well as pediatrics at our medical school, as well as in our hospital program. We implemented lifestyle medicine as well as mind-body medicine and integrative medicine into our University of Pittsburgh School of Medicine in a monthly lecture in family medicine, as well as 2-week and 4-week electives, so that they can get their feet wet before they ever get to see patients, so that they really truly understand how we put this at the center of primary care. We have lifestyle medicine interest groups that actually bring the community in so that we can make sure that our community understands, creating those blue zones and healthy communities, just like you're doing with the hackathon, and celebrating the success of your community, because when the community is stronger, then we are that ripple that changes the world. We also have our lifestyle medicine residency department where we started with just me, and now we have almost 15 people that are in our department, including health coaches, dietitians, a project manager, as well as 6 physicians and a physician assistant who are helping us, as well as our health coaches are really a key player in our team. We have over 50 board certified providers in multiple specialties in our system, which I think is really important because it's not just primary care. It should be in all the things that we're talking about today. And so I'm so proud of each and every one of you for showing up today in all your different specialties and bringing this into the world. So our footprint at UPMC is not just in the United States. It is actually also in Europe, in Croatia, Italy, as well as Ireland. I'm going to show you how big our footprint is. It is clear across the state of Pennsylvania, as well as into New York and into Maryland. And so you can see that we have quite a wide footprint. And so what I had to do is really think about, how do I break down these silos and create systemic change in such a big area? Well, it starts with self. And one of the things that I think is most important for each and every one of us sitting here today is to know that you are that change. And so we are revisiting the time needed to provide primary care to patients. And we also know that doctors really need 27 hours in the day, and we don't have that. So physicians we know that are practicing lifestyle medicine are actually happier as well as healthier. And so I ask you today to take a look at this prescription. This is a lifestyle medicine prescription given by the American College of Lifestyle Medicine that's available to you, that you should look at yourself, as well as you can give this to patients. I just heard someone in one of the last lectures saying, what would it be like if we had that? Well, guess what? We have that. So you can take this today. And I ask you, as you're sitting there, what is it that you think that you might want to work on in starting with you? These are the first steps to health restoration. And you can really start with any of the 6 pillars of lifestyle medicine, and it's forever going to be changing. We already talked about the blue zones, but maybe that's where you're starting. You're just going to start by eating some of the blue zone rich foods that might be helpful for brain health or rheumatological issues. The other thing is considering the American College of Lifestyle Medicine has a Blue Zone certification course, which I think is really important for being able to create that change, not just in ourselves, but also in the communities surrounding us. So emotional intelligence is really important. As physicians, actually, we're not very emotionally intelligent creatures. And why is that? Well, when we walk into a room and a person is coding, what do? Well, we don't say, I'm sorry, I can't help. I have to go to the bathroom. I'm sorry, I'm hungry right now. I'm sorry, I'm tired right now. We discount our own human needs, and then we take care of the patient. And so what we really need to do is to learn to come back to ourselves. And we're going to talk about what that looks like. We know that providers that are more emotionally intelligent have a better well-being, as well as better patient outcomes. So it also improves burnout, as well as increases patient safety, as well as patient satisfaction. So emotional intelligence is really essential for being having this well-being in yourself. And I think oftentimes our families did not ask us, how are you feeling in this moment? Really starting to explore your own emotions. So thinking about that self-awareness, that self-management, that social awareness or social management, really coming into, as Dr. Melissa was talking about, that breathwork practice, like starting with ourselves. I only have 15 minutes to talk to you this morning, but I did a breathwork practice out here with some people in our small breakout session. But I really do believe that we should just check in and listen to our breath and know that as long as we're breathing, we're safe and we're well, and there's more right with us than wrong with us, and we have the ability to begin again and make a change. So taking a look at this emotion wheel, you could start anywhere on this emotion wheel and just thinking about, what am I really feeling in this moment? If you take nothing away from me, really look at this and say, I have the ability to reconnect from myself, from that, medical training or residency training that disconnected me and made me think of everybody else out there, whether it was my children or my family or my patients. And this is why I say I wanted to be that example. I became a mom in 1991, and I wanted to be that change. And I wanted my son to be able to look at me and say, my mom is taking good care of herself, so I want to take good care of myself as well. So training our physicians, this is how we're really training the physicians of the future. This is happening. And so my world is virtual as well as hybrid in person. And I will share with you, because of our big footprint, we use Teams, and we put the residents on Teams. And so they're able to go in on a computer screen and do that virtual lifestyle medicine evaluation of the patient. And the patients love this because they're getting that extra added one-on-one care. I have my residents trained, first of all, to check in with themselves and reconnect to themselves and see how they're doing. And then also share with the patients that this is hard stuff. This is hard to do. But what we're going to do is we're going to say, how's your sleep, exercise, nutrition, stress management, substance use, and connection with others? What's going really well and what are you struggling with? So we have trained residents from all over the world, including had people from Saudi Arabia jump into our virtual group medical visits. And we've even done hybrid blended, where we've actually had people boots on the ground in a teaching kitchen with our dietitians. We're cooking together at food pantry sites where the patients are getting food delivered because not everyone has access to food. Our lifestyle medicine is 100% covered by insurance, which is really important to me. We also offer street medicine. Then we go out and administer care to the homeless on the streets. We also send food out to the homes via Instacart to get food out so that they could cook along with us, and then carry that out to our residency programs across the state. Our hospital is the Lifestyle Village, actually has the first 3 floors dedicated to lifestyle. So it brings the community inward so that we have things that are programs for the community for healthy cooking and art and different ways that they can connect. We know that physical health, social health, the social determinants of health, as well as mental health, are important, and putting lifestyle medicine in the center of primary care, as well as all specialties, as well as all sciences, are important. So social prescribing, my dear friend Dr. Melissa Sunderman and I were just at the United States inaugural Social Prescribing Summit with the leaders from Australia as well as UK, and I think there was someone else that was there. And we were really talking about how can we prescribe getting out there and being with others and create these healthier communities. And so I offer 24 different types of group medical visits that are 100% virtual. I will tell you that this is the way to increase access to care, because you can see 12 to 14 patients at a time and upwards of 20, depending on what you're doing, by just opening the doors and creating this virtual space to bring people together. And if we don't have the group medical visit, we build it. We're working on one for brain health, like we were talking about. Anna was talking about the 5 M's. We merged that with the 14 dementia risk factors, as well as the 6 pillars of lifestyle medicine, and we're doing studies on that. So looking at the power of shared medical visits, fostering participant connection, enhancing brain health, hormone health. I actually just created the toolkit for menopause for the American College of Lifestyle Medicine. It is a 59-page handout that you can give at the click of a button into your patient instructions so that you can help. And we teach a 5-week menopause group medical visit. So really we're doing this all through whole person care, through holistic, integrative mind-body practices. I start every group I lead with a breathwork practice. And we're going to buzz through some of this. You already know the definition of lifespan versus health span, and we want to maximize the health span. How do we do that? Well, we are looking at really targeting these chronic diseases and trying to have different models of care. And so I realize that for the sake of time, we need to buzz through some of these, but the social connection piece is really important. And we're going to be working on enhancing well-being through integrative approaches. And so things like meditation, mindful movement, mindful eating, mindfulness impacts the way we sleep, the way we move, our cognitive performance, and then also getting out there in nature. And so we are also using AI in healthcare. I was actually in the New York Times for the work that I did in AI in healthcare, and just presented as keynote at the American College of Lifestyle Medicine, talking about how we leverage this to be more mindful as physicians by using technology.
3 minutes.
Some of these slides were created by AI, and so I would encourage you, if you don't know how to do that, to lean into these different things. So I think we're going the wrong way. So burnout is important to take a look at, because we need to connect our mind-body practices. And this is a book by the Center for Mind-Body Medicine that explores this. I was in the New York Times during COVID times for that, and it is really important to take a look at that. And when we look at even some of the more cutting edge evidence-based that we're looking at psychedelic-assisted psychotherapy or ketamine-assisted psychotherapy for treatment-resistant depression, anxiety, as well as physician burnout and prevention of suicide, just different things that are being studied at the University of Pittsburgh. And that's just the information. So we know that our patients can listen better because they have better notes if we're using AI. How do we do that? We push start and we push stop. We've built digital platforms to take all the ACLM handouts, making a healthy salad, making a healthy smoothie, making nourish bowls. We put them on our YouTube channel. The UPMC YouTube channel has all these recipes that are there for patients to click on so that we don't have to do it live and in the space with them. So please like and subscribe our YouTube channel so that you can use this for your patients as well. Here's a picture of the toolkit, and I only have 2 more slides left. This is a picture of my beautiful team that again just started with 1. And so I encourage you, I have been doing this work for the past 20 years. Be brave, be strong, be the change that you want to see in the world. Sprinkle lifestyle medicine everywhere you go. And really, I think that, that is the end message here. My personal website is wholeheartedmedicine.org. I have a ton of resources on how to build group medical visits. I'm happy to talk to you about that. I've been running them for the past 3 years, and we continue to keep growing and growing. We're working on one with Dr. Sunil Kumar, who wrote the book on prehabilitation, and doing prehabilitation group medical visits prior to cardiac transplant, as well as lung transplant to show improved outcomes, as well as bladder cancer patients prior to radical cystectomies, showing that lifestyle medicine can improve outcomes. And now we are just going to have to do the build and the research to support that. So I thank you very much for your time and allowing me to be here yet again with you in the beautiful kingdom. And I am just thrilled, and it's such an honor. So thank you.
Thank you, Dr. Mishair, for your presentation. It was very nice and interesting to know all those kinds of services, and we will have more questions for you in panel discussion. Moving to the last talk, which is interesting, entitled Connecting Critical Care to Lifelong Wellness, with Dr. Abdullah Al-Hammad. Dr. Abdullah Al-Hammad is Associate Professor of Clinical Pharmacy and Consultant Pharmacist at King Saud University. Please join me to welcome Dr. Abdullah.
يعطيك العافية. السلام عليكم. مساكم الله بخير جميعا. الصوت واضح؟ معليش I forget So first of all, I would like to thank the organizing and scientific committee for this great conference and for having me here to talk to you today about a population that I'm very, very passionate about taking care of them. So I would like to switch the gear from population that we have seen from our speakers like today and yesterday to a different patient population. And you will see how integrate this into lifestyle medicine. So by raising of hand, how many of you know someone who has been admitted to the ICU and has been in mechanical ventilation in addition to other support and then survived the ICU stay? Can I show hand? Okay, I bet if I ask you about how are these patient population doing after the ICU, you might say we noticed some changes. And that changes is not unexpected for ICU population. The changes could be cognitive, could be mental, could be physical. We have done some advancement in taking care of ICU patient, from being like this to have a patient who able to mobile while in the ICU despite whatever device they have during their stay. So, as my colleague Anna said, the care of ICU patients after the ICU, after they survive the ICU, it comes with responsibility. This is a true story of 2 patients who describe their life after ICU. So one of them, he said that I struggled with reality at the time, and he appreciated the support of his family member throughout the journey after the ICU survivorship. The other patient, he said, I used to provide support and help my colleagues at work, but now I have accept support from others. So their stay in the ICU has impacted the quality of their life after the ICU. So this is my objective for today, to try to find some key opportunities for follow-up care of ICU patients. I wish we have data from Saudi Arabia, but we always have data from USA as well as other European countries. But in USA, there are more than 5 million admissions to the ICU on an annual basis, and about 4 million survive their ICU stay to discharge. However, survival in ICU, surviving ICU stay does not mean recovery. There is a different journey after the ICU. What has been a focus in the last 10 years is about the post-intensive care syndrome. About 50 to 80% from patients who discharge from the ICU will have that syndrome. And I believe this is where lifestyle medicine become not just beneficial, but very, very essential. So PICS, or post-intensive care syndrome, is a new or worsening impairment in physical, cognitive, and mental health function that are very common in ICU survivor. They have a couple of symptoms. If we talk about mentally, we talk about anxiety, depression. If we talk about cognitive, could be something like memory loss. If we talk about physical impairment, could be something like muscle weakness, and that impact their quality of life, as well as some financial burdens of taking care of these patients, whether at home or in nursing discharge or long-term care facility. And also it's impacted not only the patient, but also the family that taking care of that patient. So there are some risk factors that has been identified about PICS, some of them non-modifiable, like age and gender and disability pre the ICU. Some could be modifiable or potentially modifiable. It depends what we do in the ICU, as well as some risk factor that could help the patient after the ICU or minimize the consequences after the ICU. It's good to hear from the patient themselves. So this is a study that looked for 300 patients, mean age of 62, almost 60% are male, about their concern of intensive care, after the intensive care. So the top one is the highest, and the bottom is the lowest. So their major concern was surviving the ICU, but I'm being very disabled and require ongoing care. The second one is never being able to come home, so they're afraid they will not be go to home, but will be living in assisted nursing home. And then they have loss of list. The latest one is dying. So their major concern is the disability, as well as not being able to come back home. They don't worry about dying, at least from our ICU survivor. This is a nice study that looked for health-related quality of life in Saudi Arabia, and they look for different domains, and it's consistent with other findings that our population also reported that physical dysfunction as well as rule limitation is the major concern that impacted their health-related quality of life. And it's interesting, all these findings are independent from their chronic disease, pre the ICU admission. Mental health impairment after the ICU is very common. We did a study among a small cohort of COVID patients, and we found at least 1/3 of the patients have either like anxiety or depression at least 6 months after surviving the ICU. There are some tools that has been developed and validated to assist the patient, and there are some work also in tools that could be used by the family to assist their patient after the ICU. It's not only emotional, but it's come with very social as well as financial significant impact. And this is the study that looked for a patient and their family. And the financial impact was very high, both the individual as well as family. Some of them, they lost their job because of the disability they have after the ICU. This is a study that looked for the outcomes that that has been assessed for patient ICU survivors, short-term follow-up or long-term follow-up, like 1 year or 5 years. And in the table, you can see the category of the outcomes that has been evaluated. You can notice that we always have like good follow-up after 1 year, but after 5 years, we lost that kind of follow-up. Just to simplify it, better ICU outcomes was associated with patients who have good employment status, higher social economic status, good income, as well as good education. And the worst ICU outcome, post-ICU outcome, was with racial minorities as well as people with low social economic status. So are we ready to taking care of this patient? This is a study that looked for very elderly patients who survived the ICU. It's good that the mortality risk for a patient who will be admitted to the ICU is going to decline. But are we preparing to what's happening after they discharge? So this will be associated with more patients who will be discharged from the ICU, and they need either like assisted care or nursing facility or long-term care facility. So the question will be where we can impact the ICU survivor journey to improve their outcome. There are different key points that has been a lot of discussion and studies about it, whether like starting from the ICU, moving to the discharge to the floor, and then the transition care period, which is very critical after leaving the hospital, and then having a post-ICU clinic, which is a new concept in the ICU, has been tried in some centers in the USA, and I'm not sure if there is a similar experience outside the USA. However, this has always come with barriers that related to the patient or financial or environment that need to be taken care of. One of the things that has been done for the ICU patient is to understand what the discomfort they might have in the ICU stay. There are a lot of things that can lead to patient discomfort, as well as family discomfort for their patient in the ICU. This is the whole diagram that looked for 360 degree of things that can impact the discomfort of the patient in the ICU. This is also the study that looked for the patient, let's say, experience and how to improve their stay in the ICU. I'm not going to be able to read the statement. Same thing has been done to the family, but I focus on simple things. We always struggle with the patient who admitted in the ICU about the visiting time. And most of the hospitals, they have very restricting visiting time policy, which can impact the patient's recovery as well as the family awareness about their patients. Also using some family leaflet that could be understandable to simplify the jargons related to medical terms that we use for the ICU patient, so they can better understand how's the patient doing and what you expect from the patient. This is just a slide to show you there are some studies that looked for the outcomes of the family members, which is very important now aspect in the ICU. I like, while I'm preparing this lecture, I found this website. So Dr. Lee, she's a nurse in Scotland who, trying to help the patient and their family understand what's going on. So she came up with very, very, very comprehensive guide for the patient if they are communicatable, as well as for the family, because we believe that improving communication, both at individual as well as family level, has been highlighted as the most important intervention for improving family experience. And she came up with this poster. It's very, very huge. It's talk about the patient from the time they get admitted to the ICU until the time they get discharged, as well as the follow-up, what you expect. She tried to answer all questions that the family, as well as the patient, might ask about their health progress. It's available, and I think there is a big version of that under development. from Clinical Society, Society of Critical Care Medicine, as well as European Society of Critical Medicine, has paid some attention to that, and they have developed guidelines related to post-intensive care syndrome, as well as ICU weakness. The recommendation for the mental health of the ICU patient, there are some patients who might be at higher risk of developing depression or anxiety or mental health impairment after the ICU, and they defined who are these patients who might be at higher risk. And there are some tools that has been validated to be assessed. But the question will be, when these patients leave the ICU, who's gonna look to these patients? The usual pattern or the usual pathway, the patient will come back to his primary care physician, and the primary care physician probably will not be aware about all things that happening to the patient to the ICU. So this is the concept where we need to focus on the ICU patient immediately after the discharge of the ICU, so we can navigate the best care of them at long-term level. Also in UK, they have established what they call INSPIRE program, which is a program or a clinic that look for the ICU patient after discharge. They have shown some very positive outcome results for these patients. There are also some interest in the ICU to focus in sub-individuals, subpopulation who might need focused attention after the ICU, such as cardiac arrest, who might probably losing their neurological function after their cardiac arrest. And in fact, this is a study that put 4 clusters of the patient, and they try to study which cluster has improved or positive outcomes after the ICU. Cluster B, which represent the middle-aged patient with a few pre-ICU middle-aged patient with a few pre-ICU impairment, has the highest quality of life scores. So this is kind of help the healthcare system to focus in which group probably that you need to pay more attention to ensure that the quality of life after the ICU is not impaired. If you look for category 1, which is represent healthy patients pre-ICU, but they admitted with high disease severity, they have the largest decrease in their quality of life. I will end with these 2 slides. Society of Critical Medicine have established Thrive program, which refer to transforming healthcare recovery and integration through volunteering as well as evidence-based support. And they try to put some point that hopefully will improve the care of the patient based on the feedback from the patient themselves as well as healthcare provider. Some of them, such as identifying quality improvement target, simple things can be done when the patient discharged from the ICU to have a detailed discharge summary that sharing with the primary care physician so better understand what to expect from their patient, as well as education the staff through clinic visits. So having the staff going to the post-intensive care clinic was very meaningful to see the progress of their patient and the tremendous amount of effort and sometimes the burnout that the healthcare professional might have in the caring for the ICU, to be rewarding for them to see that their patients are progressing and doing well. And in addition to other points. Last thing, IC and the clinic represent 2 different care settings. So this is kind of a proposed solution that has been ongoing in some center in USA as well as UK to help the recovery and rehabilitation of the ICU patient. You might find it under various names such as ICU recovery name or Bixi clinic or etc. My take-home message is patients and their family face very significant challenges during and after critical illness. I hope يعني إن شاء الله with مؤتمر حائل تكون the initial beginning of considering this patient population in our mind, and do not forget this important patient population because we expect them to survive ICU, but we expect them also to have significant impact in their physical function and other things. Thank you all for listening, and I wish I added something to you. Thank you.
Thank you, Dr. Abdullah Al-Hamad, for your insightful perspective on bridging acute care to long-term health. This we conclude our individual presentation and move to the panel discussion. Please all the speakers join me here on the stage. Thank you all for your great presentation. Actually, in this session, it is a unique session. We start from the most critical care setting to the lifestyle modification that we care about the patient before he gets B6. I will start with from acute to the chronic, who talk about Dr. Abdullah Al-Hammad, how the critical care setting is critical for the patient in terms of disability, from cognitive behavior, and so on. From this perspective, you have presented in great presentation and very well illustration. From your standpoint, how we can applicable the model of AM care post-discharge patient from ICU setting?
Thank you, Dr. Abdulaziz. I think, first of all, awareness is very important. Awareness for the patient, for the family, about what they expect after the ICU survivorship is very, very important. From the model of care, I think there is a huge gap in the model of care, not only in Saudi Arabia, but across the whole world, about what to do with this patient. As I mentioned in the presentation, this patient will go immediately to their primary care physician, who are going to take mostly the care of their chronic disease. But probably there are some hidden problems that the patient need focused attention, and that's where I think the model care should focus, what to do with this patient immediately after the ICU discharge. So the proposed clinic is the ICU clinic, critical care clinic, is very innovative idea, but the implementation for that need, let's say, collaborative from different stakeholders, specifically when we talk about the payment, reimbursement, and the bundle of care of the ICU patient after they discharge from the ICU.
Thank you so much. It is interesting and an innovative strategy to take the patient from acute setting to the stable setting and monitoring, not readmission. Moving to part of diabetic patients. Dr. Abdurrahman, you bring with us today a new concept for us as a clinician. We used to have patient, we need to control him. In terms of achieving the strategy of remission, from your perspective, what's the barrier that you think from our health system that not deliver this message in clinical setting, also in health institution, and what things in lifestyle medicine you mentioned, it's higher than metformin intervention. What kind of lifestyle medicine need to be intervention to be taken in terms of many factors that in lifestyle we could offer?
So that's a great question. So why do we not talk about remission in general of diabetes? Because it's not part of mainstream. But it's an important concept to start infusing into our practice. Number two, our clinical setup is not set up for helping patients go through remission, because if you want to target remission in a patient, you have to switch gears completely, change your approach, because the 10 or 15 minutes that you spend in a regular clinic to manage diabetes, prescribe the medication, listen to what they're saying for a few minutes, provide them with a follow-up appointment and labs for the next visit. It's a completely different setup if you want to induce remission. If you want to induce remission, you're going to take them to a whole different aspect. You need to understand how they're eating, what they're doing, who's supporting them, who's cooking at home, what kind of physical activity they're doing. So my first visit with such a patient who is interested in remission of diabetes is a 1-hour visit. with the dietitian sitting next to me, clinical dietitian. So we take shared history, we delve into the deep things related to their life. Plus, you need frequent follow-ups. You need health coaches. You need a whole system, basically, to help people go through remission. So it's a different mindset, different clinical setup if you want to achieve that goal.
Interesting. I cannot agree more on that. So that this is why I start the panel discussion with the most acute to the patient from in-house, in hospital. And moving now to Dr. Anna. Anna, from your perspective in geriatric clinic and care, what barrier do clinicians face in integrating lifestyle medicine into geriatric care model?
The biggest burden we're facing, specifically in the United States, is the fact that it's very difficult to get compensation or enough compensation for all the money that has to go into an holistic care approach like this. It's very costly, and we don't always have the insurance companies on our side to provide this kind of holistic care. That leads to a lot of burnout under our providers because they have to do so much to keep the care going, and many times it's all on the physician. So what we are trying to do in our space is to focus on an interdisciplinary care model where everyone takes equal responsibility for the care of the patient, and that we work and really strive for value-based payment models that we can strive for to get the payment we need to provide a quality service. If you don't do that, it's a lot of burnout that happen in the practices.
I see. Thank you so much for sharing this kind of things that might be to be taken consideration when we implement it. We are heading to have all these kind of services in our health sector, and we will share more conversation and upcoming days or event to get your point in this aspect. Moving to the last part of our today panel discussion with Dr. Mishai. Doctor, in terms of 24 services you provided in your clinic, and you integrate many skills, emotional intelligence, patient interview, sharing the diet, and so on from those perspective of longevity and lifestyle. How we can offer this kind of services in our health services from your experience, and how it's going to be changed also the mindset of the patient to change him from doing the, let's say, unhealthy habit to healthy habits?
Yeah, that's an excellent question. And so really it is creating a paradigm shift and changing the entire fabric and culture of healthcare. And in my opinion, it is starting with our learners, because once they see this from the very beginning in their medical education, they don't unsee it. And so if our medical students and our residents are learning this from day one, they're learning how to run, and I only have 24 different types of group medical visits. I could have 50. Really, and that would increase the span of the care. And you just have to dive in. I think that's the other thing is, initially you may not know what you're doing, but I mean, in medicine in general, it's see one, do one, teach one. And my door is always open to come and spend a day with me or an hour with me or a moment with me virtually, because again, together, that's how we will transform healthcare, from all of us working in that collaborative approach. And it can be done, and it is being done. And we're witnessing that today in this wonderful conference here. So thank you so much.
Thank you so much. Interesting. I just learned a lot of what kind of physician can offer. Is not just treating the patient, even though we can go beyond to this level to change their habit and also to change their life, to not see them in hospital rather than to see him in lifestyle and coaching clinic, and to preventing the chronic disease and increase the burden on the health system. We can conclude our session with those questions, and also I would like to take this a moment to thank all the speakers for sharing your great perspective in terms of lifestyle modification, geriatric and chronic disease management, and in terms of also acute care management. Thank you so much. Thank you for all audience who join us this session.
Now welcome our honored speakers and moderator on the stage to receive our appreciation for your meaningful contributions.
Medication helps, but it's lifestyle that really shape long-term health.
On the other hand, movement, sleep, nutrition, these are the foundations of chronic disease prevention.
So this conversation leads us to a question. Which one do you feel inspired to improve?
Let's find out with our next session moderator, Dr. Raghad Al-Saif, Saudi Board Certified Ambulatory Care Clinical Pharmacist, Ambulatory Care Practitioner at King Saud University, King Saud Medical City. تحصل.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. So good afternoon all. It's my pleasure to welcome you to session 5 entitled of Chronic Diseases Prevention and Management Integrated Lifestyle. So we'll start with our first speaker in this session, Dr. Mshabbab Asiri. He is the General Director for the Medical Record in Ministry of Health. Dr. Asiri talk will focus on how the medical records and health informatics form the backbone for the lifestyle medicine. So kindly joining me in welcoming Dr. Asiri.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. I would like to talk about the role medical record and health information in the framework of lifestyle medicine. The data-driven foundation, health information management, or health informatics, and medical records play a fundamental role in the lifestyle medicine. They provide the data-driven basis for planning, implementing, and monitoring treatment. What's the goal? Ensuring effective, targeted care to improve lifestyle. You know, تعرفون الجميع أهمية السجلات الطبية في مصادر الداتا والمعلومات الصحية بشكل عام. طبعا الداتا اللي حتجمع بناء عليها يتم عمل الخطط العلاجية أو أي أنظمة تطويرية للنظام الصحي بشكل عام. The comprehensive assessment and baseline data collection، التقييم الشامل وجمع البيانات الأساسية، تسجيل وتحليل العادات مثل التدخين والنشاط البدني والنظام الغذائي وما يتعلق بذلك، توثيق البيانات الأساسية وهو أساسي في عملية الدوكيومنتيشن للإنفورميشن مانجمنت. The second, developing personalized and evidence-based treatment plan. طبعا النقطة الثانية اللي هي وضع الخطط العلاجية شخصية ومبنية على الأدلة، مثل تصميم الخطة العلاجية مخصصات لكل مريض بناء على ترخيص، بناء على التاريخ الطبي وأهدافه، تحديد الهدف، الاستخدام البيانات لوضع أهداف ذكية بشكل عام. الثالث اللي هو المونيتورينج اند مانجمنت، المتابعة الدولية وقياس النتائج، المتابعة الدورية وقياس النتائج، رصد التغييرات في السلوكيات والنتائج السريرية بمرور الوقت، تحليل البيانات لقياس فعالية التدخلات وتعديل الخطة العلاجية إذا ألزم الأمر. فقرة رقم 4 فورث the coordination and بالتنسيق بين الفرق الرعاية الصحية متعددة التخصصات. الحاجة إلى فريق متعاون من كافة التخصصات أيضا، وتعمل السجلات الطبية كمنصة موحدة في الأنظمة الإلكترونية. The fifth, supporting and improving the patient. دعم المريض وتمكينه، التوعية والتحفيز المريض، استخدام البيانات لتقديم رسوم بيانية وتقارير توضح تحسن المريض، تسهيل الوصول، تتيح السجلات الإلكترونية للمريض الوصول إلى خططهم الصحية لزيادة المشاركة والمسؤولية. الخلاصة أو conclusion. The medical records the main source for the information يعني هو الأساس في إصدار مصدر البيانات والمعلومات الصحية. نشكر الجميع، شكرا لكم.
So thank you, Dr. Mshabba, for this insightful presentation. So our next session will be delivered virtually by Dr. Janelle Gordon to talk about the live medicine and liver health. Dr. Janelle is a triple board certified family, obesity, and lifestyle medicine physician, an assistant professor in the Indiana University School of Medicine. So, Dr. Janelle, thank you for joining us today, and you can start sharing your slides. Dr. Janelle?
Hello.
Yeah, you can start. Go ahead.
Are you able to see the slides?
Yes, go ahead.
Okay, thank you. Hello, I am Dr. Janelle Gordon. My hope was to be there with you all in person. As I was last year, I'm wearing my pin. I appreciate you all for sharing the pictures. It does help me feel like I'm there, and I look forward to being back in person with you all next year. So today we will be discussing lifestyle management of metabolic dysfunction associated steatotic liver disease. I have no conflicts of interest to share. Our learning objectives today will be differentiating from metabolic dysfunction associated steatotic liver disease, or MASLD, formerly known as NAFLD, and MASH, which is metabolic dysfunction associated steatohepatitis, formerly known as NASH. The risk factors of these diseases, prevalence globally, complications, evaluation, and most important, the reason why we're all together today is lifestyle management. So MASLD is the accumulation of excess fat deposits in the liver in an individual who does not consume excess alcohol. And it's important that we stress the point of excess alcohol because these individuals may consume alcohol. However, that's not the driving force for this disease. Without treatment, we do know that MASLD will progress to MASH. And I want to make the distinction that MASLD is the umbrella term. MASH is considered a form of MASLD. And so in order to meet diagnostic criteria, a patient would need to have those fatty liver deposits as well as at least one other trait associated with metabolic syndrome. And that includes excess weight on the frame. For individuals, that means a BMI greater than or equal to 25. For our Asian patients, they actually can present with metabolic syndrome at a lower BMI. So for those individuals, it's a BMI of 23 or higher. Or we can use waist circumference, and that differs between male and female patients. We also know that there could be signs of insulin resistance, and there are various ways for us to measure that. More commonly, we will use a 3-month blood sugar average or a hemoglobin A1C. Other criteria include an elevated blood pressure. Just in the last couple months, we know that we have updated guidelines when it comes to diagnosing and managing high blood pressure. So now a blood pressure from 130 to 139 systolic or 80 to 85 systolic, 80 to 89 systolic, diastolic is considered high blood pressure stage 1. And it doesn't have to be both. It can be either elevated systolic or elevated diastolic. An individual may have elevated triglycerides or they may have low HDL, which we know is a risk factor for metabolic syndrome, as well as cardiovascular disease. So globally, MASLD affects over a third of adults. Almost 2/3 of individuals with type 2 diabetes actually have MASLD. When we talk about individuals who are overweight, almost 80% of those individuals likely have MASLD. And 90% of adults with obesity worldwide actually have MASLD. So historically, cirrhosis's underlying cause was most commonly alcoholic liver disease. We now know that MASLD is on trend to be the driving force of cirrhosis and need for liver transplant worldwide. When we talk about our pediatric patients, it's important to understand that they're coming right behind us as adults. So in my practice, I actually do see children who have aged out of pediatric GI and are now being seen in my weight loss clinic within the Department of Gastroenterology and Hepatology. And so up to 14% of children and adolescents actually have MASLD, and almost 50% of children with obesity have it. To distinguish MASH from MASLD, we need to understand that now there is actually inflammation and scarring associated with the excess fat in the liver. And without treatment, various complications can occur, and not just within the liver, but also outside the liver, especially extrahepatic cancers. So globally, the prevalence of MASH right now affects about 5% of adults, and over a quarter and over or up to 2/3 of individuals with MASLD. Around 34% of those with overweight and obesity are affected by MASH. And this just again shows us some of the possible outcomes as it relates to MASLD. So cardiovascular disease is actually the #1 cause of death of individuals who have MASLD and MASH, and that could be related to the heart failure, arrhythmias, including atrial fibrillation, which is a common one in MI. And then, as I stated, extrahepatic cancers are also common, especially colorectal cancer. Some of these individuals with MASLD may already have insulin resistance, including in the form of type 2 diabetes or prediabetes. However, some individuals may not develop insulin resistance until after their liver disease has progressed. Commonly, I also see patients in my practice who do have chronic kidney disease stage 3 or higher, and some of these individuals are in need of transplants of liver or kidney. So when it comes to evaluating the patient, within lifestyle medicine, we know that we like to use person-first language, and so that includes our patients who carry excess weight on their frame. We want to be very careful when we're working with learners, and even when we're working with patients and their family members, that we don't, and even our clinical support staff, that we don't say the obese patient. We really need to make sure that we're saying a patient with obesity, a patient with MASH. I like to inquire about the patient's food and beverage intake, and not just within the last day, but taking it back some, at least 3 days back, to see what are they actually taking in. Oftentimes foods are being demonized, and it's not necessarily that a food in and of itself is bad, but it could be that the preparation method could be optimized. I like to know, as it's been stated in that last panel, who is actually purchasing the food for the patient and who is preparing the food as well. Because if it's not the patient, it is important that we get buy-in from that individual to help the patient improve their outcomes. And then what type of cooking equipment does the patient have? Do they have access to refrigeration? Some of our patients have less resources than others. When it comes to physical activity, it's important to know if a patient is moving their body regularly, and if not, what are those reasons why? Is it because they're experiencing dyspnea? Do they have some chest pain? Is there a history of musculoskeletal injuries or disorders? If so, have they seen a physical therapist? Is a referral needed? Do they have access to a gym?
3 minutes.
Okay. If they don't have access to a gym, possibly a smart device is available. And then, is the community in which they inhabit safe? We also like to talk about sleep, which we know has been severely underutilized in terms of assessing a patient's overall well-being. But we do know if we're not getting adequate sleep, that can drive cortisol, increase our hunger, and that can lead us to take in more ultra-processed foods, which can worsen liver disease. And then again, who all is in the household and what are the responsibilities of the patient in front of us, as well as previous treatment plans? And so within lifestyle medicine, we really like to ensure that we're using shared decision-making with patients while we help them improve their nutrition, physical activity, sleep. And if there is some behavioral health concerns, it will be very difficult for a patient to make intensive lifestyle changes. So we may need to refer out to our behavioral health specialists or those who have experience in addiction treatment. And so when I'm evaluating the patient, again, I do like to know what their mental health state is. Obviously, we'll do some labs. And then I do want to draw your attention to the FIB-4 index, which is a new calculation that we can use to determine an individual's risk for developing cirrhosis from their steatotic liver disease. And so if an individual's FIB-4 is greater than 1.3, then they have an increased risk of cirrhosis. And these individuals should be managed with hepatology or by hepatology. Again, with lifestyle being the basis of treatment and additional medications and procedures as needed. If it's under 1.3, then those of us in primary care can manage those patients. And if it is under 1.3, we do want to make sure that we're checking annually, at least annually. And the reason why lifestyle management is important is because only about 1 in 3 prescribed medications get filled. And actually, most patients are only adhering to about half of their medications. In the past, we've used lifestyle in addition to medication and treatment, but we really want to drive home the point with patients and our colleagues that lifestyle should be the basis of treatment for all chronic disease. And so these are just showing how the driving force of metabolic liver disease is the consumption of ultra-processed foods, sugary beverages, and lack of physical activity. On the flip side, if we focus on a more whole food, plant-based nutrition, we do know that that can drive down oxidative stress on the cellular level, drive down the inflammatory cytokines that are being released, and actually not just treat, but even reverse some of the fibrosis that's taking place in the liver. And so I always encourage my patients to assume a more plant-forward nutrition, making sure that they're getting in enough fiber to help with that fat metabolism, improving fat metabolism and decreasing those fat deposits and inflammation in the liver. I encourage them to take in 1 to 2 servings of leafy green vegetables daily. That could be cooked or raw, and a combination is always going to be better, as well as plant protein, including at least 1 serving of beans daily, beans or lentils. And then when it comes to our whole grains and even starchier vegetables, we only want those to take up 1/4 of the plate. I encourage individuals to move towards darker rices such as purple or black. Even consider using the grain quinoa or the seed quinoa, which we actually treat as a grain and has a better protein to carb ratio, or a wild rice blend. When it comes to breads, whole grain is going to be best, as well as sourdough and rye breads, especially the sourdough because of the fermentation. That's going to help with blood sugar stabilization. And so when it comes to coming up with goals for patients moving forward, we'd like to utilize SMART goals. For example, patients will say, well, I want to eat better at breakfast. And I say, well, what does that mean? And so we may work with them and they may say, I want to make sure that I'm using steel cut oats at least twice a day in the morning for the next 2 weeks. And depending on how that goes, I may increase it. So we want to make sure that they're actually choosing goals that are realistic, measurable, and timed. And then when it comes to sleep, we really need to do a deep dive into the patient's background. Are they at risk for sleep apnea? Again, that can drive their metabolic syndrome and worsen their liver disease. Are there areas that we can help them improve and come up with a SMART goal to get better sleep and decrease that cortisol, which is driving the pathology? And lastly, I just want to make sure that we don't feel like we have to do this alone. It's very important that we work with the team. In my practice, I do work closely with the dietitian as well as the psychologist. And we know that studies have shown us that when patients see a provider and a dietitian, that their outcomes are going to be better. From an MSK standpoint, if the patient is struggling with certain areas of their body, consider doing referral to physical therapists and really get to know what the resources are available in your community and that patient's community, so that we can really give them wraparound care. Thank you.
So thank you again, Dr. Janel, for your contribution and taking from your time to joining us virtually. By that,
thank you.
Yeah, thanks so much. We hope to see you next year, inshallah. So with that, we will move to our next speaker. It's a truly honored and pleasure to introduce Prof. Abdulaziz Al-Hassan. He's a professor of clinical pharmacy at King Saud University and consultant in chronic disease therapeutics at King Saud University Medical City. Prof. Al-Hassan completed his professional training at the University of Arizona Medical Center and hold Master of Public Health from the School of the Public Health in the United States. Today, he will speak about chronic disease prevention and management, a field which he contributes throughout both clinical practice and academic leadership. Prof. Abdulaziz, we invite you.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. First of all, thank you for the organizing committee for inviting us to Hail International Lifestyle Conference. It's indeed a pleasure to speak in front of you and to share with you some ideas about being healthy and preventing diseases. يعني if you are here since this morning, multiple talks tackled the different lifestyle challenges, starting from primary care, moving toward chronic disease management, and then ICU point of view, and also from coaching and helping sick people to live longer and healthier. My talk will be about the role of other healthcare providers in providing preventive medicine or promoting healthy lifestyle. As we all know, درهم وقاية خير من قنطار علاج, or what we call it, an ounce of prevention is worth a pound of cure. If we apply this or wisdom on a daily basis of our lives, we will have a better life, healthier and happier. Before I get started my presentation, I have to highlight two main things. King Salman, Malik Salman حفظه الله خادم الحرمين الشريفين, in his quote, if you open the 2030 vision, the first page or first 2 pages is about a say from King Salman about the vision of healthcare sector in the upcoming years. And he says that we should provide the best healthcare to everyone on this earth, regardless of their religion, of their race, of their nationality. Every single human on this earth should receive the best of care. And also the Crown Prince, Mohammed bin Salman, highlighted the importance of providing the best care. They are not just talking about providing the best care, but also they putting too much hope and plans to prevent diseases and to promote healthy lifestyle. And if you look to the following pages on the Vision 2030, you will see the plan on how to live healthier and to prevent diseases from different perspectives. And all of us here, either physicians, pharmacists, nurses, public health specialists, anyone can contribute to this vision, either in this country or worldwide. So preventive medicine definition and objectives were discussed in details in the previous slide and the previous presentations and yesterday, and they will also be touched upon the next few days. But who should provide preventive medicine or healthier lifestyle? For sure, all of us, healthcare providers in the first place, and also the supported teams from Alliant Health or from any other lifestyle coaches or any experts in the lifestyle. But we should all contribute to work together for one goal is to be or to live healthier and to live better. So the role of clinical pharmacists or the pharmacist in providing preventive medicine is very obvious. So you can think of a pharmacist doing a polypharmacy or a medication management review, or a pharmacist who is providing a vaccination, or a pharmacist who is also promoting healthcare, disease screenings. All of these opportunities are provided by pharmacists. But why pharmacists? Any one of us, if you will seek help, medical help, you will go to your nearest healthcare institution, which is a community pharmacy. And in each neighborhood, you will have like multiple community pharmacies around us. So the first easy access healthcare facility is community pharmacy. And we as pharmacists or pharmacy technicians, we should provide our part in promoting health and also preventing diseases, either through vaccinating the community, screening chronic diseases, providing consultation, deprescribing if possible, and so on. So one of the speakers this morning mentioned that most of chronic diseases are discovered by chance. People will just go do like a random lab work, or will it happen to they walk in a mall where they have a campaign and they will just do like a blood sugar check, or they will do blood pressure monitoring or like checkup, and they will find out that they have abnormal results. However, the point of preventive medicine is to prevent or to do screenings ahead of time to prevent any diseases, or to prevent any complications if the patient is already diagnosed with that disease. And I think pharmacists can play a major role in providing screenings, in preventing diseases, and also in promoting health if possible. As I mentioned earlier, the first and easiest part or easiest healthcare facility is the community pharmacy. We have to use that facility to tackle all of public health issues, particularly screening diseases or vaccinating people as possible. In a study that we published in American Journal of Hospital Pharmacists a few years ago, and the folks here from the United States know about annual wellness visit. Annual wellness visit is a free service provided by Medicaid for a specific population. They can go to a primary care center, get their health checked up from all perspectives, chronic disease screenings or cancer screenings or any other thing. So this paper measured the impact of pharmacists in providing annual wellness visit. And for sure, the pharmacists provided an impactful service to prevent diseases, to educate patients, and also to promote health. And one major factor, one of our speakers earlier mentioned that they face a problem billing insurance companies for some services. I think that was that we highlighted in our paper here, that pharmacists were not recognized as healthcare providers, and they cannot bill for preventive medicine or for providing annual wellness visit when possible. But I think now the story is different. I know some states now have recognized pharmacists as healthcare providers, and they can bill for this service or for more medication management, or also for other services like vaccination and so on. I'm going to talk in a few minutes about our model here in the kingdom, where we adapted international recommendations in preventing diseases in our clinic. So we have this pharmacist-led diabetes management clinic, where we deal with diabetic patients and controlled most of the time, and we try to fill the gap with consultants to reach the targets as soon as possible. So the clinic was running as most of our diabetes management clinics, where the patient will be evaluated for A1C, and then they will modify the treatment plans if possible. But what we did, and last few years, we introduced some preventive measures that can be applied to our population. So I'll go over, this is an example. So each patient will come to the clinic. They will receive the following services as usual, which are, these services are the diabetes complications. So we just want to make sure that the patient didn't develop any of these complications, and also to prevent any diseases. So these 9 or 10 services are provided for all patients, regardless of their age or regardless of their gender. So they will be checked for renal function, for eye examination, thyroid testing, monofilament, and so on. But what we introduced recently is to divide the patients based on their gender to receive 2 major services, preventive measurements, just to make sure they don't develop or they don't have these issues. So any female patient will receive a mammogram referral and also a DAXA screening, just to make sure they don't have any abnormalities in terms of breast cancer, or they don't have any abnormalities in bone health. So, so we refer patients at specific ages to receive these 2 services. Also, for all male patients, we ordered PSA just to check for any abnormalities in the prostate, and also to check for any signs of colon cancer. So these like few added services, we introduce them just to make sure that the patient receives the best care, and also just to examine the importance of having preventive medicine in our clinic or in our diabetes management pharmacist-led clinic. So in addition to that, we do depression screening, we do immunization, and so on. But what we found after doing these referrals, that we found 32% of our patients have abnormalities in the mammogram, or have abnormal mammogram results. They never know about it. It is the first time to do mammogram, and the first time to know that they have some abnormalities in their breasts. For PSA, 23 male patients have enlarged prostate-specific antigen, or have enlarged prostate somehow, and they were referred to urology to follow up for any abnormalities. For female patients also referred to do DEXA screening, we found that 12% of them have either osteopenia or osteoporosis. And as you may know, that treating a patient with osteopenia or osteoporosis is very difficult. It's very costly treatment, and it takes a very long time to cure or to bring patients back to normal healthy bone. So we found out that introducing these simple screenings can save a lot of monies, can prevent these diseases ahead of time, also can prevent any complications or, God forbidden, death due to unscreened or unknown or undiscovered or undiagnosed diseases. I think the major role of our part as clinical pharmacists is to fill this gap through our community pharmacy setting, providing screenings as possible, adapting international recommendations with vaccination, with chronic disease screenings, and also educating and promoting health for all patients walk in to these pharmacies. And I think insurance companies should take a responsibility to play part in preventive medicine or preventive diseases by reimbursing all of these screenings, and for all healthcare providers that they're providing these services. This is all. Thank you so much.
So thank you, Prof, for this great presentation. So our final speakers is Dr. Anupama. She is a board-certified nephrologist and a lifestyle medicine physician with over 20 years of experience in the kidney and cardiometabolic health. She currently serves as the medical director at major health partners in the United States. Today, she will talk about the lifestyle medicine and the healthy aging from kidney perspective. Dr. Anupama, please join us.
Thank you so much. Good afternoon, those of you who are still awake and with us.
And thank you to the scientific committee for your warm welcome to Hael. It's been a very eye-opening experience, and I can't wait to take so many lessons back with me from what I'm learning here today. So today I'm going to talk to you about lifestyle medicine and healthy aging from the kidney perspective. I'm not sure that any of you have thought about like crouching down where your kidneys are and taking a look at lifestyle medicine or healthy aging, but I'm going to invite you to do that with me today. So this whole concept of longevity and kidney disease, chronic kidney disease as a compounder or multiplier of aging is a pretty well-known concept. In fact, there was a joint call to action last year between the Japanese Nephrology Society and the European Nephrology Society. And that's because kidney disease is essentially longevity health. You know, just because you live longer doesn't mean you're going to live well. And we've talked about this concept of health span versus lifespan. And so unfortunately, as communities live longer, they have a higher burden of disease. And those patients who have chronic kidney disease have an even higher burden of disease. So unfortunately, we have poor understanding of drivers of CKD in the elderly. So wouldn't it be great if we could stop CKD and prevent it and reverse it earlier on before we have to deal with all the burdens of CKD in the elderly? So what is forecast for 2050? So right now, or as of 2022, CKD was the 10th cause of global death, and it is going to be moving up to the 5th. But when we look at communities with longer life expectancies like Spain and Japan, it is the 3rd cause of death projected for 2050. So as your community lives longer, we're going to have a higher burden of death related to kidney disease and a higher burden of dialysis. But where do we put our attention? Everyone, when we talk about chronic kidney disease, is worried about dialysis, and I'm just going to show off for a minute. If we look over here, this is my brand new dialysis clinic that opened in 2020, and off in the distance, you can see the rural community hospital where I work. The county has about 45,000 people, so you can see it's quite a small setting. But where should our attention be? Should it be on dialysis? Should our attention be in primary care? Or should it be in the CKD clinic with chronic kidney disease? There's a lot of places to look overall, and also as a nephrologist, where do I put my attention? Because everyone's paging the nephrologist. So what do we see in chronic kidney disease? We see acceleration of aging. In fact, CKD has the largest impact in increase to organ-specific biological age. Now, I haven't figured out how to reverse biological age, but it turns out that with kidney patients, you can increase chronological age by over 8 years, and this is reversible with lifestyle medicine. Interestingly, the big jumps that we see in acceleration of aging are at ages 40 and age 60. So now if we want to look at something very scientific, we can look at lots of different ideas of why CKD leads to whole body aging. There's a lot of different things going on, including loss of gerosuppressors, accumulation of uremic toxins, and disruption of interorgan communication. And as any of you who may see patients in the hospital know, frequent episodes of acute kidney injury. And that leads to whole body aging, like I talked about earlier. In fact, you can see that biological age can really increase exponentially over time. In fact, if we look at some data, on the top, we have data showing the incidence of kidney replacement therapy, whether it's dialysis or whether it's transplant. You can see that as an older age, the numbers really jump. This data is from European countries and Japan with longer life expectancy. And then the other interesting thing is the bottom 2 slides, which show that the increase that we just really don't know what's causing end-stage kidney disease, chronic kidney disease in the elderly. And here we can see the breakdown on the left for men and on the right for women. So this is another thing. We all worry about dialysis, right? I was telling you, where do we put our attention? We have these older patients, And we think about the burden of dialysis perhaps because of the cost and also because of the psychosocial impact and loss of quality of life, especially in patients who are 75. But it turns out only 1 in 10 patients with chronic kidney disease makes it to dialysis. What happens to all the other patients? No, they don't just all decide they're going to go to conservative kidney care. What we find is that they have cardiovascular death. So if we look at some of the cardiovascular outcome trials, we can see here, just looking at that, at the cardiovascular outcome trials, look at how many of the patients also have chronic kidney disease. And then if we look at the red bars, we can see the acceleration of decline in kidney function given the severity of kidney disease compared to someone with just cardiovascular disease and without kidney disease. So basically, there's a traditional idea of silos of medicine, right? Different diseases. We're treating diabetes, we're treating CKD, we're treating CVD. But what if we looked at all of it as aging disease? What if we didn't think of it as a silo of disease, but rather as a framework of aging? And then again, we have to decide, where do we put our attention? Dialysis, hospital, and CKD clinic. And what I'm seeing over time is that, sometimes we get this consultation for what a GFR of 59, which is like, is that really chronic kidney disease? Is this age-related declining kidney function? Guess what? Maybe age-related declining kidney function is chronic kidney disease. So what if we could see these GFR of 59, where the patient is just dipping their toe into the pool of chronic kidney disease? And what if we could apply lifestyle medicine and they never have to visit the pool again? Versus a patient where we're struggling what to do because they're deep in kidney disease, make decisions about transplant, dialysis. So let's talk more about preventing CKD and maintaining kidney health. And the Kidney Disease Improving Global Outcomes Controversies Conference gave me a lot of good ideas about this. So there are some patients who are going to get disease and there are some patients who aren't. And the key, I think, is to identify the patients who are going to get disease and intervene early. And if we look at the different examples across the bottom, we can see it ties directly into lifestyle medicine and our 6 pillars. One of the most important risk factors for CKD is older age. Now, what do we already have to look at kidney function? Well, we have the heat map. How many of you have seen this heat map before? The CKD heat map. So what we have in the CKD heat map on the left side is GFR, and across the top is albuminuria, which requires a urine specimen. So the CKD heat map has been out for 30 years, but yet, at least in the United States, we're not having good uptake on checking for albuminuria, which means we're missing so many opportunities to find people with kidney disease for early intervention with just a little bit of urine, which was going to get flushed down the toilet anyway. So the big idea in the consensus conference was, how can we identify pre-disease, right? So if we look at this table right behind me, we can see that we have a pretty good start in GFR. Then we have kind of a decline in GFR, but we're not calling it CKD yet. And again, we can have some minimal albuminuria, but we're not calling it CKD yet. So wherever it is that we're calling CKD is already late. It's already established disease. But look at the model for diabetes. We have diabetes, we have pre-diabetes. We don't really know what is pre-CKD.
Excuse me, the time's out. 2 minutes, please.
Okay. So basically, there is a CKD blind spot, but I would say that we can find that if we look at higher risk patients. And what we learned from Dr. Ibrahim this morning is, I think that you're already screening your high risk patients. And fortunately, you have a big lifestyle program, so that I think is the answer. So where I work, I have a cardio, kidney, metabolic health program, and actually, the cornerstone of that program is clinical pharmacists who do chart reviews and look at guideline-directed medical care. And then I myself also integrate lifestyle medicine. And we know that lifestyle medicine and kidney care overlap with plant-predominant diets, exercise, and focus on all the pillars that affect blood pressure. So this is another table showing that we're missing opportunities for high-risk CKD for guideline-directed medical care if we wait for the diagnosis. And I think the key there is screening early and screening often. And that way we can keep our patients out of the swimming pool of kidney disease. So I'll give you one case. I saw a patient just last week, the last patient before I left for the trip. She's a 73-year-old, creatinine of 1.2, and has a diagnosis of obesity, hypertension. I think she had an elevated creatinine and got referred to me. My intervention was lifestyle medicine. We stopped sugar soda. She transitioned to retirement and started going to the gym 4 times a week. And then she was mindful with her portion size. Well, she's down 26 pounds. Her creatinine is approved and she's got minimal albuminuria. And we were able to deprescribe 1 medication. Thank you so much.
Thank you, Dr. Anupama, for this presentation. So I would like to thank all our audience for joining us until this session. So there is any question for Dr. Anupama or any speaker from the audience? So due to the time limiting, so I would conclude my session, and I would like to invite all the speakers. Dr. Abdulaziz, Dr. Anupama, you have a question? Please, can we have mic there? دكتور عبد العزيز، دكتور أنيباما، دكتور عسيري.
Hello.
Thank you so much for this very conclusive and practical talks for all fabulous speakers actually. I have one question regarding the fatty liver, that one of the lectures talking about fatty liver and related to lifestyle, and if there was a correlation between especially the soft drinks and fructose with fatty liver.
معلش ترفعين صوتك دكتورة عشان Okay.
Hello.
Yes, my question is regarding the relation between soft drinks, fructose, with the fatty liver, especially this one, and if there is a correlation, and if they cut off this soft drinks, that will be reversible or no?
Do you hear
Is
the
this
question
for me?
Go ahead.
Is this question for Dr. Janelle Gordon?
Yes.
Oh, okay. I've been messaging you all because I haven't been able to see the presentation. I didn't know when we were doing the panel discussion. One moment, please. Can you please repeat the question?
Okay. Actually, my question is regarding the relation between soft drinks, fructose, all these related to fatty liver, even in early age, as a causation or correlation. And if we cut off these soft drinks, it will be reversible or no? That's it.
Yes, thank you. Great question. So actually, we did go right through that slide in the presentation. I enjoy seeing the pediatric patients who have now aged out of peds GI because we really want to work with them to optimize their nutrition. That's where we're going to have the biggest bang for the buck, especially working with parents. And not just pop, but also fruit juices that are not 100% natural juice, such as Kool-Aid in America. So we know that if we can help an individual lose around 3% of their total body weight, that can actually start to reverse some of the fat deposits in the liver. And if we can get them down to 10% of their total body weight, we actually have studies that are showing that we can reverse the scarring in the liver. So this doesn't have to continue to progress to cirrhosis, hepatic cancer, and even cardiovascular disease leading to death.
So thank you, doctor, for your answer. So moving to Dr. Anupama. So Dr. Anupama, from your opinion, what is the impact of using a groundwater source rich in minerals and heavy metals, chemicals, which from environments such as city of Hail for the dialysis units?
I imagine there is quite an impact on that. I don't see that in my area, so I haven't worked closely with that, but I do remember studying it. So that probably bears more study.
Great, thank you. So moving to Dr. Asiri. So شكرا دكتور مشبب، أخذتنا من ناحية ثانية من يعني من توجه نمط الحياة. سؤالي لك دكتور، من وجهة نظرك إيش هي أبرز التحديات خلال جمع بيانات المرضى وتطبيقها على نمط الحياة واللايف ستايل ميديسن؟
طبعا we don't have one system for collection of all the information. That's maybe the التحدي الرئيسي للمعلومات. يعطيك العافية.
عافية دكتور، شاكرة لك. So ending by Dr. Abdulaziz. So Dr. Abdulaziz, you mentioned a wonderful like clinic that have been or services implemented by clinical pharmacists. So how far we are from completely addressing a complete preventative clinic led by pharmacists? To implement a full preventive clinic.
Thank you for the question. I think the major challenge for most of our hospitals here are adapting the concept of pharmacist-led clinics, the model that we want to see. As you know, some hospitals have some limitations in terms of manpower, or infrastructure, and so on. So if we apply the question on how far we are from adapting, from having a full pharmacist-led clinic providing preventive medicine in our tertiary reference hospital, I think we are ready, and I think we have been doing it in some hospitals very well. The thing that we are missing is including more patients from the community, not only for, as you know, if you are in this hospital, you are limited to this type of population, but if we are open and we are using community pharmacies to recruit patients and to do screenings, I think this would provide more better outcomes.
Doctor, thank you all, and moving to speaker recognition.
Thank you, our respective speakers and moderator. Let us recognize you. Thank you so much.
Continuing our focus on chronic disease prevention, our next moderator will guide you through the rest of this session's topic. Please welcome Dr. Abdullah Al-Shammari, Consultant General Surgeon and Laparoscopic Surgeon, Medical Director at King Salman Specialist Hospital, and trainer in the Saudi Board Program for General Surgery. Please welcome, Doctor.
Assalamu alaikum wa rahmatullah. I'm happy to be in this wonderful conference to take care about the lifestyle medicine and to have ways to achieve our goal to get to 80 as an average years of life. The second